Hello everyone. Good morning or good afternoon, wherever you are joining us from. Congratulations on being accepted onto GP training and a very warm welcome to both the profession and the college. It's lovely to see you all. My name is Azza Elghonaimy. I'm a GP in West Yorkshire. I had my primary medical qualification in Egypt and I completed my training in 2017 after 6 years of training as less than full-time trainee. I am also a fellow of the college. I'm in the RCGP National Elected Council member, the Yorkshire Faculty Honorary Secretary, and the IMG representative, and a member of the RCGP IMG Special Interest Group. It's my pleasure to be co-chairing the event with the wonderful Dr. Sylvia Kama-Kieghe. She's our chair of the RCGP IMG Special Interest Group. Over to you, Sylvia.
That's amazing. Thank you so much, Azza. Well, a very, very warm welcome, everybody. It's so great to have you all here. Congratulations on getting to this stage, going through the different exams and the different challenges and becoming an ST1 registrar. So very warm welcome to you all. Thank you so much for joining us today. As Azza has said, my name is Dr. Sylvia Kama-Kieghe. I'm a GP based in Sheffield, which is in the north of England. And I'm also the chair of the South Yorkshire North Trent faculty. And as you're going to get to know very soon, there are different faculties across the country. And I look forward to seeing some of you who will be members of my faculty in due course. I'm also an international medical graduate. I finished from the University of Lagos in Nigeria. And I completed my VTS in 2009. And so the experiences and challenges that come with GP training, we know them, we've lived them, and we're happy to say that regardless of those, general practice, a fulfilling career, and we're so happy to have you with us today. I'll hand things back to Azza to take us through the housekeeping.
Thank you, Sylvia. So in terms of, next please. So in terms of the housekeeping, everyone, so if you have any question, please just use the Q&A function, not the chat. We're not going to look into the chat if that's okay with you, because we are expecting about 355 delegates. So it's very hard for us to trace through them. Answers will be provided in the Q&A box, as well as in some sessions, the speakers will be able to verbally as well answers. The webinar is recorded and will be recorded, and the content will be made available for a limited time after the event. I'm sure the event team will be able to let us know exactly the duration when you will be expecting to receive the recording. Please complete the feedback form when it is sent to you, and it's always be shared in the chat at the end of the meeting. Over to you, Sylvia.
Yes, so we have a very packed day for you today. Before we start off with the very first part of the program, let me just quickly run through the plan for you today. Starting with interviews with some of our college leaders. That will be in a very few moments. And after that, there'll be a session that provides a detailed overview of what you should expect during training as it concerns exams, assessments, and so on. That will be followed by myself and Azza sharing some points about arriving and settling into the United Kingdom and hoping to address some of your questions in that area. Just before we break for lunch, we'll have a presentation on a topical issue that affects medical training and recruitment here in the UK from the RCGP Head of Campaigns and Public Affairs, providing us with an update on the new medical training prioritisation bill. Lunch is at 1:40 sharp. And following that, we will discuss legal and regulatory issues with our regulator, the GMC. But before that, a session with one of the UK's medical indemnity providers, the MDU, and they'll be sharing insight into issues around our practice and when things do not exactly go to plan. But just to give us some thoughts on that. So we're going to go into the interview circuit. And so it's my pleasure to welcome two very important speakers that are going to talk to us about their training journey. So let me start by introducing them to you first. Dr. Alexandra Abel and Dr. Eman Shamsaee, both are RCGP, GP Registrar, co-vice chairs, and they're very important because they are your representatives in the college. So Dr. Alexandra Abel is a GP registrar in Hull and a new co-vice chair of the RCGP Registrar Network. She's currently undertaking the Future Leaders Program. Alex is passionate about advocating for colleagues, protecting well-being and ensuring all registrars have a positive, supported training experience. And Dr. Eman Shamsaee, Eman is a GP ST3 registrar in Hull, president of the Hull Medical Society, and your RCGP registrar representative for this faculty. She's now also stepped into the role of the RCGP GP registrar vice co-chair to continue supporting and uplifting registrar voices. Now, before I start the conversation with my guests, the GP registrar co-vice chairs have prepared a poll, and we would appreciate you, that's on the next slide, we would appreciate if you can complete this while we're speaking. The slide should be up very soon. You can use the QR code or use the link to join and send your response in, please. So now, Eman and Alex, I'm so pleased you could join us today, and thank you for coming. If I can start with you, Alex. I've kept the intros brief, so to give you the opportunity to expand on yourself. Tell us a little bit about yourself, please, and your journey in the medical career to this point, Alex.
Sure, thank you, Sylvia. And yeah, thanks so much for having us here today. It's really lovely to be here. My name's Alex. I'm originally from Northern Lincolnshire, and I now live and work in East Yorkshire. So I was kind of born one side of the Humber Bridge, and I now live and work on the other side of the Humber Bridge. And I really love living and working in Yorkshire. And I did my primary medical qualification in the UK in Hull, and I've actually worked here ever since. So I'm not an IMG, but I'm really passionate about advocating for all trainees and supporting them and making sure that everyone's having a positive training experience. And so that's really important to me. So I graduated in 2019, pretty much just in time to become a COVID doctor. And then in between my foundation years and my GP training, I did a clinical teaching fellowship year, which was just a really valuable teaching experience. And I absolutely loved doing that. And I would really highly recommend any kind of out of program experience that allows you to do fellowships like that and get a bit of extra experience. And then I went into GP training, and I actually went into GP training having never had a rotation in GP. So in my foundation training, I'd done a lot of COVID cover. I'd done 2 different cardiology related rotations. I'd done cardiology and I'd done cardiothoracic surgery. So I started GP training feeling very confident about anything to do with cardiology, and much less confident about anything else. And my clinical experience in my foundation training was actually very challenging. And I did have an alternative offer for a non-clinical career in public health. And it was a really difficult decision because I am also very passionate about public health as well. But the idea of GP was really, really exciting to me, and just something just told me that I needed to explore that and do that training. So I started my GP training in Hull in 2023. And honestly, it has been the best clinical experience I've had. I think it's a really exciting specialty. It's a really supportive training program. And when I started my ST1, I got a bit more involved in leadership, took on some roles locally that were advocacy roles, and I've really enjoyed doing those. And then the opportunity came up to do an out of program year with the Future Leaders program in Yorkshire. So that's a leadership fellowship year where you get some leadership training and you get to have some focused mentorship. So that's what I'm currently doing this year, which has coincided quite nicely with the RCGP co-vice chair role. So I really love GP training, and I hope that you all will as well. And I also love all things creative, including music and theatre. Before medical training, I was actually based at the Royal College of Music, and I was doing some project work in an area called Creative Health, which is about how creative arts can benefit your health and well-being, which is an interest I still have now as well. And I think that's really kind of shaped the way that I think about health, and things like social prescribing. Have a huge appreciation for that. And I just wanted to add that anyone who has had a career outside of GP, whether that's a clinical career or a non-clinical career, or anyone who has interests or hobbies, that's a real strength in GP training. Because the care that we give is obviously very holistic and patient-centered, and it's very relational. So GP training is the time that you can kind of celebrate that side of yourself and all the different interests that you have.
Thank you so much, Alex. That's really interesting, and I'm glad that you've shared the fact that GPs aren't boring people. We do have lives. It's not just bones and lumps and all sorts of things, but really great to have you. Thank you so much for that brief of your experience. Can I pass things on to Eman, please, to do the same? Tell us a bit about yourself and your career journey. Thank you.
Thank you, and a really, really warm welcome to all of you lovely, new, beautiful GP registrars, wherever you are. I'm really excited to be here and get the chance to even speak to you all. So my name is Iman Shamsaee. I'm currently a GP ST3. I know I sound like I'm like almost at the end of the training, but believe you me, I feels like literally yesterday was where I was in very similar shoes, coming into GP training, coming to these induction events, and trying to figure out what I was meant to do with anything, to be honest. So really lovely to be able to have this opportunity to speak with yourselves. So just a little bit about myself. So my family are originally from Pakistan, although I've actually grown up and lived most of my life in Hull, and that is actually where I'm currently doing my GP training as well. At the moment, I'm still in Hull because I love it so much, and it's also because it's home for me. I think it's nice having being close by to family, so I think it's been a really nice time from that perspective. So when I grew up, I did all my schooling within Hull, and then I decided to do biomedical sciences actually initially in University of Liverpool, and then after doing that, I did a graduate entry into medicine in Liverpool as well. So a good 7 years in Liverpool for any of you who are maybe starting training there. It's a lovely city, so I've got lots to look forward to. And then beyond that, I actually came back to Hull for my foundation training, and I also spent some time in the across the bridge, which is what I think even Alex was mentioning. We've got a lovely bridge called Humber Bridge, and there's two areas off of that on either side. And so I did some training of mine in Scunthorpe, near Grimsby areas, and then I came back to Hull for my GP training. And honestly, just like Alex has mentioned as well, I am so glad that that is the decision I've taken to do, because with GP training, I find that you have a chance to really make a real impact, a real difference to people's lives. And I think that that aspect of holistic medicine was something I was really missing in my hospital placements. I actually was thinking of going down an ear, nose, and throat training pathway. So I initially had geared up all of my CV to do something along those lines. But the beauty with general practice is you can have your passions in different aspects, and you can actually still incorporate that within your roles as well. So maybe that's something I'll do. There's so many interests, and I sometimes struggle with having too many interests on occasion, which you'll often learn.
I have to agree with that. Thank you so much, Iman, for sharing your thoughts. You're quite right. There's so many other things that you can do. General practice just opens the doors. So thank you for sharing that. Let me come back to you, Alex. And I think you'd have had enough time in training to be able to agree that there are challenges. We're not going to, butter things up for our new trainees. We have to be upfront and honest. Nothing in life is easy anyway. So can you tell us about one or two challenges that you've been through in training and how you overcame them?
Yeah, there will be challenges, and I think the good thing about GP training is that it does feel like a community, and you have that peer support to support you with those challenges. But during my last year of training, one of the challenges that I had was that I was really struggling with the admin burden in my primary care rotation, and I think that was mainly due to dyslexia. And it did kind of get to the point where I was sort of staying 1 or 2 hours late every day after work, and this kind of became quite unsustainable. And at the same time, I did also have a health issue to deal with as well, so that sort of added an extra burden on top of that and made things a bit more challenging. And at first, I just thought, well, things will get better as I get faster, as I get used to it. And I think to a certain extent it will, if you're new to primary care or certain IT systems or the way things are done, or new to the NHS in general, there will always be a steep learning curve. But you do have to kind of balance that with the expectation that this is also a training program, and you need to have the time and support to deal with that learning curve in a way that is sustainable, and in a way that isn't going to negatively impact your well-being. And I think we're not very good at looking after our own well-being as registrars. I think we all feel that pressure to make a good impression, to be able to cope with the things that we're given. So I did let that situation go on for longer than I probably should have. But then I did speak to my clinical supervisor and my educational supervisor. So you'll have those two people who are your sort of main support system in training. And I've had really amazing supervisors, and I've had really good support from them. And I requested a bit more admin time in my day, and it was an amount of admin time that was still within the expectations set out in the BMA CogPed's Guide to the Working Week. And this did take a few weeks to implement, but when it was done, it was really helpful for me just to have a bit more admin time. And I would say even in a really good practice, there might sometimes be a little bit of resistance at some level to change, just because of the pressure of the systems, and everyone within them are under a lot of pressure. And I used to not be very good at advocating for myself. So when I was in my foundation training, especially, I found it really hard. I used to really struggle with advocating for myself and speaking up for what I needed. And I think we all do to a certain extent. I think it's really easy to diminish our own experiences and think that you might be the only person feeling that way, or maybe that even you might be the problem. And I think it's a really common thought process, and it's often something that we need to fight back against in our own minds.
Absolutely.
But yeah, I think self-advocacy is actually a really important part of being a trainee. And it just means like knowing your entitlements, knowing what you need and asking for that. It doesn't mean it's adversarial. You can do it in a way that's professional and polite. And if you ever need assistance with that, that's what our different representative structures are there for. So I just wanted to make the point that self-advocacy is not selfish. In my mind, self-advocacy is the same thing as advocating for everyone who comes after you. The lasting changes that you make mean that the next person doesn't have to kind of inherit the same situation, or that they might be supported better as a result of the things that you've raised. So in that sense, self-advocacy is actually leadership.
Absolutely. Yeah, thank you so much, Alex. I'm so sorry to cut in. I'm just very conscious of time. But I think you've done a lovely job actually in responding to that question in terms of the challenges and highlighting. The next question I was going to ask you was about tips, and you've managed to cover that as well. So thank you so much. So we're going to end with Eman now providing us, and I'm sorry, Eman, that we've got just a couple of minutes, but if you could also do the same for me, please, and provide us maybe one challenge that's really striking. And then just as Alex has done, what 1 or 2 tips would you provide for the registrars? And we can round up this session with you. Thank you.
Of course. So I think Azza's done a really good job. So definitely, guys, do advocate for yourselves as part of your training from that perspective. I think one challenge for me is, as I said a little bit earlier, I had so many interests, so many passions, and sometimes you can start in ST1 trying to think that you can challenge and do everything all at once. But take your time, enjoy the ride whilst you're doing it, because it can be difficult to try and take on too much all at once, I would say. So ask questions. No question is a silly question, is what I would say. I asked so many questions throughout my ST1, and I think asking all those things is what's actually helped me overcome a lot of my challenges throughout. Because if you don't ask, you don't get. So do make sure that you ask anything. And if there is any way of you incorporating aspects that you think might be easier for other registrars, do try and implement those changes as well alongside, as Alex has mentioned. One of my challenges that I've definitely faced is with my portfolio. It can be a bit of a mind boggle when you first get onto things and try and figure out where you're needing to go, what things to do. But just taking some time out, spending some time trying to figure out, okay, you know what, where is everything, can be really helpful, because then you can actually see, okay, these are the requirements I need to do. And I always think little is often. I say this every year on my PDP that I should do 2 entries each week. And I swear to God, I'm still trying to meet that PDP because I just keep wanting to say yes to everything, which is also good. It opens doors for you. But try and make sure that you're taking on as much as you can chew, and you're enjoying the ride and enjoying the scenery of GP training as you're doing it as well.
Oh, amazing. Eman, let me let you into a little secret when you become a GP about those PDP entries. Let's not go too far. Let's not discourage people, but it's something that might continue. Thank you so much, both Eman and Alex. You've been absolutely amazing for the information you've provided us, giving us an insight into your experience, the tips and the challenges. Really wonderful. We've been speaking to the 2 GP registrar co-vice chairs, Dr. Alexandra Abel and Dr. Eman Shamsaee, about their experiences and their career journey. Thank you so much, both of you, for taking time from your busy schedules. I want to take the opportunity to say that in a couple of weeks, there's going to be a Meet Your GP Registrar chairs and co-vice chairs. I think it's the 16th of February. Another opportunity for you to hear more from your chairs and your vice chairs about how they'll be working to support you. We'll place the links to these events in the chat and hope you can join at that time. I'm going to hand over to Azza for the next part of our program. Thank you.
Thank you, Sylvia. So, I have the pleasure to introduce Dr. Amina Hussain and interview her today. So, Dr. Amina Hussain is the RCGP clinical lead for IMG Registrar, contributing to National College strategy on supporting IMGs in training. She is training program director as for the East Midlands new to NHS structured learning program, supporting IMGs to navigate training, professional culture and well-being within the NHS. Amina is an equality, diversity and inclusion lead for the RCGP Vale of Trent faculty and co-lead for the Next Generation GP Leadership Programme in East Midlands. She also works as a coach, supporting aspiring leaders and colleagues at different stages of their careers. Amina is a GP partner in Nottinghamshire with clinical interests in sexual and reproductive health and neurodiversity. Welcome, please welcome Amina. Thank you for joining us this morning, Amina, or this afternoon. So we're glad to have you here during the event and joining us today. I'm just going to be asking my questions straight, just because I'm conscious of time. We've got only 8 minutes, if that's okay. So are you able to tell us a bit more about yourself and your journey in your medical career, please, Amina? Thank you.
Yes, absolutely. And thank you for that wonderful introduction, Azza. So I was born in Pakistan and I came to the UK when I was 5 years old as a dependent of my IMG father. We faced a lot of adversity as a family.
I'm very sorry to interrupt you, Amina. Are you able to raise your voice slightly, please?
Yes. Can you hear me now?
Yes, it's yeah, please. Yeah, that's much better. Thank you.
No, so
yeah, please.
That's all right. I was saying, so I was born in Pakistan and I came to the UK when I was 5 years old, as a dependent of my IMG father. We faced a lot of adversity as a family, including frequent displacement, financial challenges, personal and systemic discrimination. And my younger brother's diagnosis with cancer when he was 2 years old, and whose passing would be one of my core motivations for studying medicine, starting me on this journey. And so I would say from an early age, I witnessed the complexity of life in migration, identity, loss, adaptation, but often as a silent and fearful passenger as a child to circumstances and systems that were beyond my control. And I would say that those early experiences really profoundly shaped my values. And much of my life's work has been driven by a determination to no longer be that silent passenger in myself, but also by centering compassion, agency, equity. I really don't want others to be left in a similar position to me. So I went on to study medicine at the University of Nottingham, by luck becoming the only UK graduate in a family with 3 neurodivergent international medical graduates. And then I undertook my GP training in the West Midlands. And after CCT in 2023, I moved to Derbyshire, where I worked through being a salaried GP, a locum GP, and an out-of-hours GP, before now becoming a GP partner in Nottinghamshire with my husband. And alongside my clinical work, I have consciously tried to align my professional roles with my core values. And as I mentioned, I'm here today as the RCGP clinical lead for IMG Registrars, but I also am an educator for the East Midlands New to NHS Structured Learning Programme for IMGs, a TPD, and I hold some voluntary roles in EDI, or Equality, Diversity and Inclusion, and leadership. And I have this small business as a career coach when I get time. So as you can see, work is a big part of my life, but I also enjoy being alongside my family, exploring other languages and cultures in whatever format I can, reading, doing jigsaw puzzles, and watching crime thrillers, Korean dramas, and animes when I can. Everyone can leave their recommendations in the chat for what I should watch next. I hope that answers
That's
that
wonderful.
question.
Thank you, Amina. And it sounds like it's been a very sort of, I would say, roller coaster experience for you since you were here in the UK. But we're very privileged to have you, and it's well deserved to be in this position as well of with these all roles to be able to help and support IMGs in training. Now, just going to ask you, so you've touched base about some of the challenges. Is there any one, or are you able to tell us one or two challenges that you have been through your sort of training as well as your career, starting career? Thank you. Or maybe just your training at the start, please.
Yeah, so I think one of the most significant and recurring challenges in my journey has been of facing discrimination. And I would say from early childhood, but also unfortunately through my professional life. And that's included racism towards, being melanated, Islamophobia from my Muslim name and when I wore a hijab publicly, and sexism and sexual harassment. And this has included overt incidents as well as more subtle microaggressions. And it's come from, as I say, both public spaces, but later, unfortunately, the professional spheres, where you least expect it, I think. Often it has meant having my credibility questioned or needing to constantly justify my presence in the spaces I found myself in. But I think what really helped me navigate this was developing a strong sense of self and identity. I learned that while others might not understand or acknowledge my journey, no one truly knows what it was except me. And the people, experiences, and the moments that shape my worldview can't be fully articulated or summarized. And holding on to that certainty became a central part to my resilience. And I'd say that holding on has taken different shapes through life. Sometimes it's looked like writing angry poetry for no audience, or speaking affirmations in the mirror, going to therapy for a time, or leaning into the power of my sisters, my mothers, brothers, and fathers in this time, and through music, art, and literature, the times before, and really reconnecting with my heritage, my roots, and sort of my ancestral homes. So I think alongside this internal work, I have sought allies and professional networks where I could reflect and be supported and advocate for myself. And I would say that the RCGP has been a core space for my personal journey in that regard, including being a trainee representative during my training, and being introduced to the college world, attending events, networking, seeing inspirational leaders who have shared a similar journey to me. And I'd really encourage others to utilize that space to its full potential, as early as you can in training.
Thank you, Amina. So thank you, and I'm very sorry to hear that you had these sort of painful experience, which I think I know we just have to be realistic. Some of us have experienced some of these as well. But in a matter of fact, you already covered some of the top tips for the IMGs, and again, self-advocacy is really important. The resilience. You mentioned also about developing sense of conquer your identity, and being yourself, and the connecting with your community, with the leadership community, and learn. Is there any other top tips you would like to mention to our colleague?
Yeah, I think I would say my first piece of advice is to avoid comparison. In my experience, many IMGs, come to the UK with a hint of imposter syndrome when they start training. And I get it, is sometimes life learning and the language we have doesn't translate as deeply as we know it to be when you're across a sea. But all too often, I think that imposter we feel is when we believe our career or training defines our worth, and it doesn't. Training isn't the story, it's a toolbox within your story, and learning the tools well and using them wisely is sensible and important, but they sit within a much larger and uniquely complex personal and professional journey. So I would advise developing that strong internal sense of identity early on. To belong doesn't mean to conform, and you may find yourself your credibility questioned more readily, or that your communication or decision making is scrutinized differently. But knowing who you are and what you bring helps you stay grounded when that external validation is inconsistent. But of course, the external still holds value. We can't be naive to that, and it can either bolster us or knock down our internal strength. So my second advice would be to be proactive about support. seek out the RCGP, your educational supervisor, training program teams, mentors, peer networks very early. Asking for help will not show you to be weaker or more unaware. It is in fact a marker of your self-awareness and accountability for your limitations, and therefore of safe professional practice in the NHS, which, you know, others and your seniors will respect. And
Thank
finally,
you.
I would say
Yeah.
just give yourself time. And I know we're running out of time, but that self-compassion can go a long way. And your lived experience and perspective and resilience are your strengths, and they add real value to the world and the workplace. And we should be in no doubt about that.
Thank you so much, Amina, and thank you for those 3 top tips. So we're glad to have you here, and thank you for joining. I'm just over to you, Sylvia.
Thank you so much, Azza, and thanks again to our guests. There's really never enough time to go through everything, but just a little bit of what we hear is always encouraging. So many thanks again to our guests. Right, let's move on very, very quickly to the next item on this agenda. We're going to go into a very important aspect of the program, and that is discussing what the next few years as a trainee will entail. There's a fair bit of information to take in, let me warn you, but we have excellent hands to guide you through this, because do they have a wealth of experience and knowledge? And I always learn something from the talks, even though I'm not preparing for SC or doing anything exam-wise again. So to present to us the Understanding GP Training, Reflective Practice, workplace-based assessments, exams, and portfolio, I have the pleasure of introducing first Dr. Onyinye Okonkwo. Onyinye is a mid-career GP. She's a fellow and trustee of the college. She has extensive experience relevant to your training, working as a GP trainer, university examiner, and an SCA lead examiner. She's deeply involved in supporting the profession at both regional and national levels in so many ways. We also have Dr. Henry Akintunde. Henry is a GP partner, a trainer, and an associate postgraduate dean with NHS England. And as an RCGP fellow and examiner, he understands the training pathway deeply. He's passionate about supporting trainees, and he brings a unique perspective from his work in leadership and as an author. I really cannot think of a stronger combination of trainers and examiners with such a wealth of experience to guide you at this very time into what you should expect during your training journey. Now, as you listen, please send in your questions to the Q&A section. Our presenters are going to address every single one of them. So with that said, a very warm welcome to you, Onyinye and Henry.
Hi, thank you, Sylvia. So honestly, I'm always amazed when you're talking, because I sometimes don't recognize who you're talking about.
It is you.
It's amazing to see 232 of you. This is brilliant, absolutely brilliant, because when I'm looking at it, this is another 200 odd new GPs. So welcome to GP training. So Henry and I are going to spend the next about an hour with you guys, just talking you through what, from our experience, what you're expecting, and as examiners, what we're expecting from you to be able to say, we give you that certificate of completion of training so that you can say, now I'm a GP in the next 3-4 years, however many years it will be for you. So Henry, thank you so much for starting the slide. Next slide, please. So this is who we are, okay? Sylvia had just introduced us, so I'm not going to go through that again. Next slide, please. So now that you know a little bit about us, we want to know a little bit about you. So I'm going to hand over to Henry so that he can run this bit of it, so that we understand who you are, your background, and how best we can tailor what we want to discuss with you guys today. Henry, you're mute.
Sorry about that. Yeah. So we're going to use the Zoom poll actually for this bit. So hopefully Giles would display that for us. We just need you to tell us your first name, your country of primary medical qualification. Let us know if you have GPs in your country of primary medical qualification. And if yes, are they based in the community or hospital? So it just helps us get to know you a bit better. So I think the poll is on now. Would allow a minute or two for you to do that, and then we'll see what sort of answers we're getting.
Okay, shall we have a look at what kind of answers we've got so far so we can crack on?
Good.
Okay, do we have a breakdown of primary medical qualification or country of primary medical qualification? Is that possible?
I don't think we can see right
Okay,
now,
that's
but I'm sure we're going to have a look. So I'm pretty sure we've got people pretty much everywhere in the world. But 83% of you did say you have GPs in your country of primary medical qualification. It will be interesting to know the 17% that don't have GPs. Who are the people that play the role of GPs? But of those of you that have got GPs, only 33% are based in the community like UK. For the vast 2/3 of you, they are based in the hospital. So this, we operate a slightly different model in the UK.
Okay. It's actually very interesting, isn't it?
Membership communities, if you please mute yourself.
They can't do it. They're supposed to be. I'm so sorry to cut in. I think there's some interference from somebody on the call. Will you please all mute except for the speakers? Can I ask everyone to please mute except for the speakers? Thank you so much. I'll just give this about 5 seconds for everybody to mute except for the speakers. Thank you so much. I'm so sorry about this, Onyinye and Henry. Please carry on. Thank you.
That's absolutely fine. This is technology for you, isn't it? So, Henry, can we share the slide again? So it's brilliant to see that at least some of us know what GPs do from the countries we're coming from, but you can see a lot of us have GPs, but they're in hospital, whereas our model is different in England. We are not in hospital, we're in the community. Okay, so what are we then going to talk about this morning? So we're going to talk about, we're going to look at an overview of our training, which I'm going to do. Then Henry is going to take you guys through workplace-based assessment and your e-portfolio and how you can reflect. And then I'm going to come back and talk to you about exams. And then we're going to have a bit of a question and answer session where we pick out the questions that you put in. That's why we're saying to you, as you listen, please put your questions in the Q&A. And if there are some that are really, you know, a lot of people are asking the same thing, we'll answer it as a group. Or while we're presenting, we'll keep an eye on the chat and the question and answer, and we'll keep answering as many questions as we can. Okay, next slide, please, Henry. So let's talk about an overview of your training journey. So what is a GP? I know some of you said that you have GPs, but it will be good for us to understand who GP are in terms of England, United Kingdom. So whether you're in Scotland, whether you're in Ireland, who is a GP? For us, the way we define a GP is a doctor that is an expert in general, everything medical, general. So we do it all. That's all I can say. That's the way I look at myself. We do a lot. We are trained in almost all the specialties. So you're going to find out that you will probably have different specialties that you will have to go to maybe for 4 months, maybe for 6 months, but we try and see a bit of, you know, we try and do a bit of everything. Everybody in England has a GP. So we are the first port of call. It's not everybody in England that goes to the hospital. I know that in some countries, everybody, if you need medical attention, you have to go to the hospital. That's not the way it is in England. In England, we are actually in the community. We're closer to people. We're closer home. What we're saying, you hear people talk about care closer home. We are within the community where the patients live, and everybody, like I said, has a GP. So if you have any medical problem, unless it's an emergency, you go first of all to see your GP. What we then do when patients come to see us, we listen to them, we hear their story, we try and find out, we diagnose what is wrong with them, and then we manage quite a lot. That's why I said to you, we tend to go and do some specialties in hospital before we then come into GP. Or we kind of these days, we run them together. So you might start up in GP, you might start up in hospital, but you tend to get a bit experience from both sides. And then that then means that we can safely manage a lot of things. So the first port of call, they come to us, we look at them, we build relationships. We like to say that we support people from the first time they are born, because when you're born, the first thing your parents will do in England is they'll come and register you with a GP. You will be probably one of the first medical professionals you get to see. We start looking after you from that day. So every patient in England has a GP that has all their medical records. So we have everybody's medical records on our system. And for us to be able to do that, we build that relationship with our patients. And beyond treating the diseases, we are the ones that tend to promote health. We talk to people about how to prevent disease. We are the patient's advocates. That's what we do. We try and support them all through their life. Like I said, from the moment they are born, from cradle until when they die. When people are dying, quite a lot of times, especially those that decide to die at home, we're there holding their hand. Next slide, please. And because of the kind of work that we do, we have to have everybody's record. So if you move GPs, we then share the records with the next GP. If you need to go to hospital, we just pull the part of your record that is necessary for that specialty and we give it to them to be able to manage it. So you hear people talk about GDPR, which is like, keeping everybody's confident, because for a patient to come and tell you all the things that are, intimate and they can't tell anybody else, you hear a lot of things that you'll be amazed about. They have to trust you to hold that information and never share it with anybody else. So that's the reason why we are the only one that has everybody's full records, but we then share it with the hospital on a need-to-know basis. So in this country, just to be aware, we do not share records. Say somebody is somebody's wife or child, or we don't share anybody's record unless they give us explicit consent for us to do that. We are also involved in teaching and training. That is why you can see Azza, you can see Sylvia, myself, Henry. We talk about being trainers and all that. So for us to be able to do that, our patients know that we do this and they actually get involved in us doing it. So you will see a lot of, when you go to your practices or to the GP surgery, you find that we do a lot of teaching and training. We also operate, just like hospitals operate, we own this small, we say clinics in the community. So we run our own businesses, we employ staff, we manage staff, we oversee our budget. So the GPs do a lot. And then we work with all the other parts of the system, but we are usually what you call the coordinator of the patient's care. So if the patient needs to go and see a heart, we work with the heart surgeons. If they need to see a respiratory specialist, we refer them, but all the information comes back to us. But I would suggest it might be a good time, because one thing we see is that people come into general practice and they don't fully understand what we're supposed to do. And then when they come into the clinic and the patient comes to you and they're telling you certain things, you're there wondering, that's not my job. Why should I do that? So my suggestion is, can you take a snapshot of this link that I've given you at the bottom? Go and have a read of it so that you understand exactly what a GP does, so that when you come, you know what you need to know. So if you find you have gaps, you can try and make sure you cover those gaps. Next slide, please. Okay, so what does your training, what is it going to entail? We say the minimum. Most people will have at least 3 years training. Now we've started this 24-12 model in England and Wales, where you spend 24 months in general practice and 12 months in hospital. So like I said to you, some of you might start off with general practice. You have 4 months here, and then you're in hospital, and then you come back, and then in ST2, you have about 8 months in general practice. but your last year is usually spent in general practice, almost being an apprentice and watching what we are doing. But 12 months is spent in different specialties in hospital. But for some of you, you might have more than 3 years, especially those that are doing an academic program. I'm sure that you've met somebody today that is doing it, in which case you might have like 4 years. Some of you might have an extension for whatever reason, either you go on maternity leave or something happens and you have to go out of training. So you might spend more than that. And those of you that are not full-time might spend longer. But when they offer you your contract, they will tell you exactly, what you're supposed to do. If you've done some other specialties and come into general practice, you might find also that your training is shorter because they will recognize what you've done before. So you might end up with something like 2 years rather than 3 years. But if you take time out, we normally allow you about 10 days all through in a year. If you take more than 10 days, depending on the reason why you're taking those 10 days out or more than 10 days, it might mean that they have to elongate your training. And that's why we ask you to fill your absences out in something called your Form R, so that when you go to see the panel that look after your training, they will be able to check whether you need to pay back any time that you've had out. Next slide, please. Okay, who do you need to know about? These are the most important people you need to know about. First of all, there's somebody called your educational supervisor. That is your biggest advocate. If you don't know them, go and find out. Ask your training program who your educational supervisor is, because they follow you for 3 years. They are the ones that will be seeing you every 6 months. And in the last year of your training, you go to their practice and they support you all through. When you're not with your educational supervisor, you're not in their practice, wherever you are, you have to have a clinical supervisor. So if you're in hospital or you're in another practice, find out who your clinical supervisor is. If you haven't met them, go and meet them, because they need to sit down and agree with you every 6 months or every training, what your training is going to be like. And you will reflect on that in your e-portfolio. Your lead employer holds your contract. So everything to do with your contract, your pay, all those type of things, if you don't know who your lead employer is, go and find out. Then, of course, there is the statutory bodies, the NHS, and those are the ones that actually hold the budget or give us the money to train you in whichever area you are in. If you don't know who they are, please go and find out. But above your educational supervisor, you have your training program directors who run your half-day release. You have your head of school. You have your postgraduate dean, and then you have a panel that meets every year to look at your whole e-portfolio. So make sure that you know them, or when you go for your training, your half-day release, listen carefully and know who you need to know about and who is doing what, so that you know how to get help if you need it. Of course, we're putting on this program. We are the RCGP. We are your professional home. Please make sure that you engage with us, especially at your faculty level, that is at your local faculty level. Try and engage with us, because we have a lot to offer you and we want to support you. You have a trade union. Make sure you belong to the BMA. So issues, contracts, all those things they deal with. You do not want to annoy the GMC. I'm sure some of you or most of you would have done PLAB. So you know how important they are. They can take away your registration. So please do not annoy them. Make sure you read their good medical practice, and so that you know what to do not to annoy them. Make sure you're indemnified. Find out, ask, because I've seen some of you think that they are indemnified, but they are not, because maybe they are transferring or maybe they are registering and they forgot about you. Find out who your MDU or is MPS at the moment now, if I remember correctly. So make sure that you are registered. Ask, because if there's anything that goes wrong, I don't think you want to pay the money that comes out of making mistakes and all that. That's what the MPS and the insurance is all about. So please make sure that you're there. And of course, we have CQC. You hear us sometimes running our helter-skelter. They are coming. They keep everybody in check, make sure we're doing whatever we're doing. So these are what we call the very important people you need to know about. Next slide, please. Okay, so I'm going to stop talking now and I'll hand over to Henry, who is going to actually talk to you about what we expect from you in practice.
Thank you very much, Onyinye. I'm just going to put on the slides again. So I'm going to be talking to you about workplace-based assessments and the things that you need to know about them. I'll give you a general overview and how to get the best out of your workplace-based assessments. So for ST1 and 2, you've got the same workplace-based assessment requirements. It's different for ST3, but we won't be talking about that today. So the first thing is about case reviews. Every time you see a patient, it's a learning opportunity. Every time you, and this applies whether you're in GP or you're in hospital post, every time you attend the teaching, you attend the meeting, they are all learning opportunities. But the RCGP requires that for 3 times a month, 3 at least a month, you write out your experience of seeing patients and what you learned from that experience. And you've got what's called clinical experience groups. So this has to do with the curriculum all put together into clinical experience groups. Then you've got, so you need to cover the whole curriculum. But along with that, you've also got capabilities that you need to develop. And there are about 13 of them that you get used to over time. Things like data gathering and interpretation, clinical management, community orientation, making decisions and diagnosis. So there are about 13 of them. So every time you see a case or you deal with a patient in practice, you need to think about what curriculum area that links to and what capability that you demonstrated in that consultation, and then do a clinical case review, or otherwise we also call it a log entry. So it's important that as you're doing that, you're keeping an eye, and because every case you could reflect potentially on about 6 different capabilities, but we only need you to do about 2 or 3 per time. So you need to keep an eye on the capabilities you're covering and the curriculum areas you're covering, because there will be some difficult to see sort of cases, and you have to be deliberate to try and cover those. So that's case review. For every post you start, you need a placement planning meeting. So at the beginning, you need to meet with your clinical supervisor and agree on what you want to get out of that post and reflect on that in your e-portfolio. Now, this is mandatory for every single placement that you do. So you need to have that in your e-portfolio. The ARCP panel will be looking out for things like that. Now, once every 12 calendar months, you will have an ESR. And I'm using 12 calendar months because it doesn't matter whether you are less than full-time or out of sync. It still has to happen every 12 calendar months. The only exception will be if you were off sick or you are out of program, or even when you're out of program, a panel still has to hold without an ESR. So you need to meet with your educational supervisor and have what's called the educational supervisor review. And that's what would lead to your ARCP panel. Midway into the year, about 6 months, and again, it's 6 calendar months, regardless of whether you're full-time or less than full-time, you will have an interim ESR, interim educational supervisor review. It's generally not as cumbersome as the full ESR. It's a bit of light touch, but I'll talk about when that's applicable or not. Personal development plan, learning event analysis, significant event analysis, we'll talk about those. Learning event analysis basically is that there are times that things don't go the way they should go, and something is missed or an error is committed. In that sort of instance, we still want you to reflect on it as a learning event and put that in your e-portfolio. If it is one where, unfortunately, there's an adverse outcome to a patient is harmed or as a result of that, then that is a little bit more than a learning event. It's a significant event, especially when it's at the threshold of something that can be reported to the GMC, we need it to reflect on that as a significant event instead and put that in your e-portfolio. And significant events and learning events need to be declared on your Form R when you come to have your ARCP at the end of every year. So we'll talk a little bit more about that. So these are some of the other things you need to do. I'm going to go into some more details about each of these ones. So let's go into some specific details. Clinical supervisor report is required for all non-primary care posts. So every post you do in the hospital or community outside of general practice, you do need a clinical supervisor's report. And it's a short, structured report that is completed by your clinical supervisor at the end of each post. Now, you also require it in GP if you have a clinical supervisor that is different from your educational supervisor. For some of you, your educational supervisor would also be your clinical supervisor when you're doing GP in their practice. But there are some practices that have the luxury of more than one trainer, and they can afford to appoint a different clinical supervisor for you than your educational supervisor. If that's the case, you do need a clinical supervisor's report from them. Or when you're doing GP in another, like in your ST2, for example, or sometimes in your ST1, if it's your second GP post, when you're doing GP in another practice different from where your educational supervisor is based at, you do need a clinical supervisor report. But sometimes your clinical supervisor may feel the need to give more evidence that they cannot give for your ESR, because when they do your ESR, their role is just to look at the evidence in your e-portfolio and make a judgment. If they feel like they want to provide more information about your training that they cannot do in your ESR, they may decide to do a CSR also, or if you feel like you would like them to provide more information. So it can be optional in that instance. Then you've got what's called the quality improvement activity or quality improvement project. The GMC requires every doctor to be involved in quality improvement activities at least once a year. So some form of quality improvement activity. And that can be entered as a GP trainee, either as a QIA or as a QIP. Now, we require you to complete a QIP when you are doing GP, either in ST1 or ST2. And the other training years where you don't do a QIP, you do a QIA. So for example, you may decide to want to do your QIP in ST2, that's fine. So in ST1, you need to do a QIA, and in ST3, you need to do a QIA. So in your 3 years of training, we want to see 3 quality improvement activities, one of which must be a QIP. A QIP is a bit of a bigger kind of work. And 2 things are important that you need to demonstrate in a QIP. One is that you must demonstrate evidence of being involved in making a change. So there has to be evidence of implementing a change, and that change must outlive your time in that practice. In other words, it needs to leave a legacy effect. So something you do that leaves a change that outlives your time in that practice. So it's not just enough to do an audit. What are the recommendations? Have they been embedded? And are those changes going to carry on beyond you? So if you do something like induction pack, you updated it and all of that, that's something that will outlive your time in practice. If you do something in a clinical area that involves making some changes on the computer system that the practice uses to consult, or a form of template or policy is designed from that, that's something that will outlive your time in the practice. It will qualify for a QIP, quality improvement project. Usually, if you want to do an audit, you would have to do a second cycle to demonstrate that the change that you suggested has been implemented and has been embedded. So sometimes some trainees will decide to do an audit the first cycle of it in year 1, ST1, knowing that they are going to come back to that practice in ST3, and they do the second cycle of the audit. That can be acceptable in ST3. In ST1, it will be a QIA. In ST3, it then becomes a QIP. So that's another way to do it. But the key thing is you've got to show the evidence that you have implemented change and there's a legacy effect. When it comes to quality improvement activities, like I said, this is on a smaller scale. And things that you can do, examples are things like a referral review. So not your own referral, but a particular referring for a particular aspect in general practice. So you may want to do a review of 2-week wait referrals. You may want to do a particular review of certain referrals that you feel that maybe things are not sort of working very well in that regard. So for example, one of my trainees did one on referral to urology, and because she also did urology in hospital, and she had the benefit of looking at it from both sides, and discovered that in our area in particular, there were certain aspects of NICE guidance that we were not meeting when we referred. And now we're at the level of trying to change the 2-week wait template based on that audit. So that's something that can come out of a referral review. Involvement in large-scale national audit. So sometimes there's an audit happening nationally and your practice or hospital department may be involved. That can be a good example of QIA that you can do, especially in secondary care. You're reviewing prescribing. There's something called a prescribing assessment in ST3. This is not what we are talking about, but maybe you're reviewing the prescribed, you do an audit of the review of prescribing of disease-modifying agents, for example, that are used for patients that are on that have got rheumatoid arthritis. That could be an important one. Writing or revising a practice policy, monitoring or evaluation of medications that need monitoring, like DMARDs or warfarin. That can be an example of a QIA. So multi-source feedback. In general practice, you're going to hear this word a lot, triangulation. Triangulation, us trying to get evidence from different angles to be able to assess your competence. One of them is what we call a multi-source feedback, where you're going to gather feedback from the members, the different members of the teams that you work with. So this would include clinicians, it will include non-clinicians. And every year, you're required to complete a multi-source feedback. So you're going to need a minimum of 10 replies. And 5 of those should be from clinicians, the other 5 from non-clinical staff. So practically speaking, you want to send out way more than 10 invites, maybe send out about 15, and making sure that at least you're getting 10 of those back to make sure you get enough response. Sometimes trainees fall short. You may get 10, but you don't get enough clinicians. You get just 4 clinicians or so. That's why you want to send out more. Ideally, probably send out double the number you need, 10 clinicians, 10 non-clinicians, to make sure that you get the sort of numbers that you need. And this needs to be done once every year. So in ST1, you're going to do this. Then you've got what's called clinical examination and procedural skills. Again, another part of the triangulation. So this is how we assess your examination skills. Okay, you probably would know, and Onyinye will tell you about it when she comes to the exam, that the exam does not involve clinical examination. So more emphasis is on clinical examination and procedural skills. And there are certain examinations that we need you to be able to show that you can perform competently. So there are 5 of them that are called 5 mandatory intimate examinations. And they include things like breast examination, male genital examination, female examination, which is broken down into 2. You need to be able to do the speculum examination, and you need to be able to do the bimanual examination. Then you've got rectal, and then you've got prostate examination. So in total, there are about 6 because the female one is broken into 2. And this needs to be observed by a suitably trained professional. And a suitably trained professional will be in GP. Anybody who is qualified as a GP can do it. A GP registrar cannot do it for you. So don't say because they are ST3 registrar, they can fill the form for you. No, they cannot. It has to be a GP. In hospital, it has to be a registrar at the level of ST4 or above. Okay. And there are different grades that they can give to you. They can say that you need minimal assistance. They can say you're able to perform it competently and safely. The one that counts for your qualification, for you to be able to qualify as a GP, is that they need to mark you as being able to perform it competently without supervision. Okay, that's the one that counts. Any other one before then would show that you're engaging in SEPs, but ultimately for it to that box to be ticked, you've got to be rated as being able to perform it without supervision. And then in addition to these mandatory ones, you've got a range of other examinations and procedural skills that are relevant to GP that you need to show that you're able to perform. So things like ear, nose, and throat examination, examination of a child age 1 to 5, cardiovascular examination, abdominal examination, and the list goes on. You need to be able to show that you can perform this also. And in addition to that, your supervisor must also be satisfied that you're competent in general and systemic examinations for the clinical curriculum areas. So these are things that they've picked from their own observation of you over time, whether it's from joint surgeries, whether it's from thoughts, them watching your video consultations, whether it's from debrief. So over time, they would have an idea of whether you're generally able to perform those examinations or not. So you need all this for you to be signed off as competent in clinical examination and procedural skills at the end of the day. Then there's what's called mini-KEX court, audio court. These 3 assess the same thing. They assess your consultations with real patients in real time, either in secondary care or in GP. Mini-KEX is in secondary care, and court consultation observation tool is for video consultations or face-to-face patients that you see. Audio is for telephone consultations. And you need any mix of court, audio court, mini-KEX whilst you're in ST1, ST2. Now, the audio court template, don't use it for video consultations. It's specifically for telephone consultations. So if it's video consultations in primary care or face-to-face, you use the court one. In ST1, ST2, you need to do at least 2 courts when you are in GP placement, okay? And the reason for that is that you're training to become a GP. Sometimes some trainees, they do everything they want to do in hospital and they come to GP and they don't do anything. So that's why we insist that you need to do at least 2 out of the 4 courts that you need in ST1 and ST2. They need to be done whilst you're in GP. And it needs to be done. So unlike SEPs that can be done by any GP, all other forms of assessment need to be done in GP by a GMC approved trainer. So a GMC approved trainer are the people that can be clinical supervisors or educational supervisors. So you need to make sure in your practice, once you get there, to know who is a trainer and who is not a trainer, because the non-trainers cannot complete courts for you and other assessments. Mini-KEX in the hospital can be done by your clinical supervisor, and ideally, your clinical supervisor needs to do one of your assessments in order to be able to complete your clinical supervisor report. So it could be done by them, or it could be done by an ST4 or above registrar, or by an SAS. So these are like specialty doctors. They are not on the training pathway, but they are very experienced doctors in the department. They also can do your workplace-based assessments for you. Case-based discussion. This is a structured oral interview to assess your professional judgment in a clinical case. So case-based discussions can be done either in hospital or in GP placement. They again need to be assessed by either a clinical supervisor, ST4 above registrar, or a specialty doctor. In GP placement, only by a GMC approved trainer. And it should be a case that you have managed independently. And it's not done as part of debrief, okay? Debrief and CBDs are two different things. Debrief is that you've done this surgery and you are discussing all the patients you've seen that day. Case-based discussion is a tutorial is going to happen. Ideally, if you want to do one CBD, if I'm your trainer, you will send me 3 cases and I'll choose one of them to use as your CBD. If you want to do 2 CBDs, you send me 4 cases and I'll choose 2 of them and we'll do it as CBD. And I would have some structured questions that I would ask you under different capabilities. So in a CBD, we may decide we want to cover 2 or 3 capabilities. And I would ask you structured questions to test your knowledge and skill of managing that patient. And at the end of the day, you'll be given a rating of whether you are needing further development below expectations, you're needing further development and you're meeting expectations, or you're needing further development, you're above expectations. And when you start to come to ST3, we can also add another category called competent, okay? Now, don't expect anybody to give you competence in ST1, okay? Because you're not. If you were, you'll be a GP already. You need further development, but you're aiming to either be meeting expectations or above expectations. Competence is when you're coming towards the end of your training. ESR or interim ESR, like I said, you need to have an annual ESR. Every 12 calendar months, you need to have one. You need to make sure that each capability area, and I told you that there are 13, you've got at least 3 evidence that are linked to them, okay? If you have less than 3 evidence, you are creating the risk that you will be marked below expectation in that area. So this is why you need to keep an eye on your e-portfolio as you carry on. As you're doing your case reflections, make sure you're ticking off those capabilities and curriculum area. As you're doing your workplace-based assessment, whether it's CBD or Medicolegal or court, make sure you're choosing the sort of cases that are helping you to cover the different capability areas. So you need a minimum of 3 evidence to be linked to each capability area. You can do an interim ESR in the midpoint if you're progressing well. If you're not progressing well, a full ESR may be required because your trainer may want to refer you earlier to an ARCP panel. So if there are concerns about trainees' performance, if there's any unsatisfactory outcome in your previous ARCP panel, so if you've had an ARCP panel where you had anything other than an outcome 1, it means that your next ESR cannot be an interim one. It's got to be a full one. Or if your trainer is planning to refer you to a panel within the next 2 months of an ESR, then a full ESR is required. So the point really is that if you're doing everything you need to do and you're progressing satisfactorily, you will most likely have an interim ESR at 6 months and a full ESR at 12 months. Urgent and unscheduled care. So as GPs, we provide out-of-hours cover. And what do I mean by out-of-hours cover? In the UK, GP practices open between 8 to 6:30 p.m. Sometimes we do what's called extended access up to 8 p.m. So 8 to 8 p.m., we mostly, that's when GP practices could be open. From 8 p.m. to 8 a.m., or in some places from 6:30 to 8 a.m. is out of hours. And there's a service that provides cover for all patients within the UK. And these are also run by GPs. So as part of your GP training, we need to make sure that you have developed the capabilities to be able to work in that setting. And that is incorporated into your training. Now, there's variation, and so the main way we test your capability in this area is you being able to work in the out-of-hours setting, okay, in the out-of-hours setting. In some instances, there are other settings that are not the out-of-hours service that you can also work in to demonstrate this capability. So, for example, in urgent care centers, in community-based services, like sometimes working with the paramedics, sometimes working with the palliative care team, sometimes you may be able to use some of those experiences and hours to count towards your urgent and unscheduled care hours. So it varies across the UK. There are hardly two deaneries that are similar in how they've organized their out-of-hours service. In some places, it is built into your rota. They'll tell you that you need to go to this place on this particular day and work for this number of hours, and that's built into your rota for the 3 years. In other places, like in East Midlands where I work, it's not inbuilt into your rota. You have to arrange it yourself. And so it's finding out what operates in your area, how many hours you're required to complete and all of that, what documents you need to complete so that you can demonstrate capability in this area. Then there are other mandatory trainings that you need to show evidence of right from the start of your training. So you're starting in February. From as early on in February, you need to show evidence of having this training in place. One of them is CPR and AED. So CPR and the use of the defibrillator. And you can show evidence of this through BLS or ALS. The difference is that BLS is done every year, and that's acceptable provided there's CPR and AED there. ALS, normally the license is valid for about 3 or 4 years, but in general practice, an ALS license is only valid for 1 year. So you may be able to show ALS as your evidence for ST1. Come ST2, you must do a BLS that has CPR plus AED. That same ALS certificate that was valid in ST1 will not be valid for the rest of your training. So every 12 months, you must show evidence of having training in that area. And the easiest way to do it is BLS. And that certificate must also be valid at the time of your CCT and extend beyond the end of training dates. We don't accept online evidence of CPR. It's got to be one that you attended in person. And your local program would have arrangements for doing that, either through your local hospital. Most GP practices also do one, because even as GPs, we need to show this evidence. So they will do one at least once a year. So if it happens at the time that you're there, you join them for the training, you get the certificate done. If not, sometimes it's organized as part of your half-day release or whole-day release, but there will be a provision in your area. And then, in addition to that, you require in-date evidence of level 3 safeguarding for both adult and child safeguarding. Now, the full training is about 3 hours, and the certificate is valid for 3 years. So right early on in your training, you need to do adult safeguarding level 3, child safeguarding level 3, and that certificate will cover you for the 3 years of your training. If you're going to be in training for more than 3 years, you need to do it again at some point. Now, so that's got to be there early on, even before your ARCP. But in addition to that, you need an annual knowledge update, okay? Something that demonstrates that you've updated your knowledge. You can easily do an e-learning module on the RCGP website to show that, or you can attend a safeguarding meeting in your practice. You can attend a training or teaching on safeguarding. You need to do something every year to show that you've kept your knowledge up to date. And on top of that, you now need to reflect on one case that you have seen under adult safeguarding and one that you have seen under child safeguarding. So a case that you saw in everyday surgery where you needed to apply your knowledge of adult safeguarding and your knowledge of child safeguarding. So for the next 5 or clinical case review, And reflection is basically, it's not necessarily a general practice term. It's something we pick from everyday language. Is the way you give serious thought to an event with the aim of learning from it. Okay, they say experience is the best teacher, but that statement is not true, because many times we have experiences that we don't learn anything from. The experience that you learn from is the one that you reflect on. So we want you to be mindful that every opportunity of contact in general practice is a learning opportunity. And we want you from time to time to sit down and reflect on it. If something goes very well, you need to reflect on what was it about that consultation that made it go very well compared to other consultations. If something doesn't go well, you need to reflect on it. What was it about that didn't make it go well? If you see an interesting case, you need to reflect on it. So reflection is giving serious thought to an event with the aim of learning from it. It's how we make sense of the experiences that we've had and how and what we have learned from them. Okay, so that's how we make sense of the experiences we've had and think about what is it we've learned from them. But what we want you to do is not just think about it, is now write it down, because it makes you think more about it. So this is how we examine our own thoughts and actions and make sense of what we already know. Because at the end of the 3 years training, or however long your training takes, we are not only interested in the skills and knowledge that you've acquired, we want to also see progression in your attitude. We want to see progression in your learning. And we want to see that in your clinical case reviews. So you now need to think whether a change in your perspective is needed, whether a change in your belief system is needed, whether a change in your knowledge is needed. So there's something called patient unmet need. Often when a patient comes to consult with you and they live with an unmet need, it's usually an educational need for you. So we call them pons and dents. A patient has an unmet need, is going to lead to a doctor's educational need. So you are going to now reflect, how do I cover that knowledge gap so I can meet a patient that has a similar need? I can meet their needs in the future. And also think about your behavior. And the process of writing these thoughts down in a structured way will cement this above process of thinking about things, what you need to change, more fully than you just thinking about it. You writing it down, it expands further and you can think about it. Now, obviously, we've got artificial intelligence now, and it's inevitable that we're going to use AI for different parts of our lives. And the RCGP has got a policy on use of AI, because there are trainees who now totally use AI for their reflection. And the RCGP policy is that you cannot use AI to generate your reflective log, okay? It's got to be a patient that you saw. AI can assist you in writing it. For example, AI may generate questions for you to say, well, for this case that you've narrated, you may want to reflect under these capabilities and give you pointers as to what you can do. So you can use AI for that purpose, but not use AI to make up a fictitious case that you've not seen and then put it as a learning log. That's going to be a probity issue that can get you in problem with GMC, like Onyinye was talking about earlier. So, but a case that you've seen, use AI as prompt if you want to use it at all to help you generate a learning log. Don't even use it to write everything for you. Use it as a prompt, because you need to still think. The thinking is the important element of it. So when you want to write a reflective learning log, it's good to think about it in these areas. What happened? Okay, what happened on the day? What if anything happened subsequently? So this started like a normal surgery and all of that, and then the patient threw this question, or suddenly the patient became angry about this. So what did you learn from it? This is the critical question. What did you learn from all of that? And as a result of what you learned, what are you going to do differently in the future? So in the future, in this case, I lost my calm. I will learn to maintain my composure and let the patient finish saying what they are saying. And I will gently then come in and explain to them, so what are you going to do differently? Then what further learning needs have you identified? And so maybe you are the sort of person that never really thought about when cases go wrong. So this may open your eyes to, I need to prepare myself for instances like this and how I would handle myself. And then as a result of that, you may develop what's called a PDP and talk about how do you then, how will you address them in the future? So that's just a quick overview of workplace-based assessment and reflection. I'm now going to hand over back to Onyinye. Thank you for listening.
Hi, sorry, I was trying to unmute myself. Henry, that was absolutely brilliant. We've had lots and lots of questions in the chat, and I've tried to answer as much as I can. And I know that Alex has also been very, very busy, and everybody else answering the questions. So thank you, everyone, for doing that. Okay, next slide. Let's talk about examination, because some people have asked some questions about examination. There is this, what Henry's talked to you about is workplace-based assessment. That's just one of the tripods. So you have to pass the 3 aspects of the RCGP for us to give you the certificate of completion of training. So the exams and the ones Henry talked to you about are the ones that you do within practice. Now, in terms of the exams, there are 2 main exams that you have to take. There is the applied knowledge test, what we call the AKT, which tests your knowledge, okay, of what you've been learning or while you're doing your training. We usually advise you to take that exam in your ST2, so that because you've done your ST1, you've done some hospital training, some GP training, and you have an idea of what is expected of you. A lot of you tend to take it in the second half of your ST2, but it's a good idea to discuss with your ES and maybe your CS about readiness to sit an exam, so that somebody else that has more experience will be able to talk you through what you should be prepared for and all that, so that you make sure you're taking it at the right time. Because you're only allowed to take it a maximum of 6 times. After that, you are removed from training, sadly, if you don't pass it. The AKT is done 4 times a year. We now ask you that you can reserve your place up to 12 months in advance. You go to a center called Pearson View. Somebody asked how much it costs. The AKT costs £470. They've made it quite reasonable now. You have 160 questions in 160 minutes. It used to be more than this. So we think that now at least you have a minute to think through, look at the question, think through your answer and answer it. 80% of it will be on clinical knowledge. 10% of it is on evidence-based medicine. Maximum attempt is 6 attempts. You can't have more than 6 attempts. That evidence-based medicine is where a lot of you get caught out, because a lot of us don't really know how to read the paper, how to interpret the paper, and how to apply it when you have, a patient in front of you, and how you can use it to answer questions. So I think it's something, if you can, start looking at evidence-based medicine now, because at least as you go through, you acquire the knowledge on how to read it. And then 10% of it will be on primary care organization and management. Like I said to you, we own the surgeries, we run the business. So when you go to do your, because it's always good for you to have an idea for your exam. And then if you please, this is a plea, listen, there is no shame in being diagnosed with things like dyslexia, okay? Or being diagnosed with autism, ADHD. We are very high functioning individuals. And what we are finding is that some of us, because in our home countries, there are not illnesses that are really easily recognized. So because we are very intelligent and we're very high functioning, we've gone through medical school and we've managed to find ways of coping. But then when we come, these exams are really high stakes and we struggle. And then you're asked all the time to do a screen and people think, no, I don't want that diagnosis. No, it's not me. By the grace of God, it's not me. There is no shame in it, please. What we want to do is diagnose you and put some support in place for you. So I would even suggest to you, if asking your deaneries, please can I do some screening just in case? Because if there is any reason, because people are dyslexic and they don't even know, and they take the AKT 4 times and then they don't pass, and then they go and have the assessment and then they start putting, don't wait for that. go and get yourself tested. If they say there is a testing or screening done, go and get it done. So if you have the diagnosis, we support you. It's not about blame, it's not about shame. There are so many college CPD courses, and that's why the college is putting things like this on to just inform you that this is available for you. Go and have a look at it and arm yourself. Don't go into a battle without knowing what you're going to be seeing in the battle and the tools you need to fight your battle. Go and look at the CPD courses. It's all free now because you're part of the college. Next slide, please. Then the one that you do in your last year of being a GP is your simulated consultation assessment. We tested your knowledge with your AKT. This is when we then test how you're using that knowledge to manage your patient. Like I said, it's done in the last year. You can reserve for it 12 months in advance. Usually it's done in your GP surgery, but if for any reason it can't be done in your GP surgery, they will tell you where else it can be done. We do it every single month, apart from December, July, and August. So there is no rush into doing it without being ready. Have a conversation with your ES. You can see the price, £1,180. It comes out of your pocket. Don't waste your money. Make sure you're ready before you take it and have those necessary consultations. Usually it's 12, it's like a morning clinic. Yeah, you get to see 12 patients, but are simulated by role players, and each of them lasts 12 minutes. You don't have to examine any patients or they'll give you the examination findings. Now we're putting on seminars for people that are coming to it. Please don't go attending those seminars at the moment. Maybe ST2, you can start attending them. Or if you just want to know, you can go and see how consultations are done. But concentrate on this maybe in your second year, because it's good to learn how to consult, what is expected of you. And again, this is another one. If you finish your 6 attempts and you don't pass it, they will release you from training. So when you pass the 3 of them and everything has gone well, we then say, the deanery will see you, that you have your last ARCP panel, they make a recommendation to the college, we give you that certificate of completion of training. The RCGP will look at your portfolio, agree with the deanery, send up to the GMC, and that's how you become a GP. And while all that is going on, they ask for you to put your name in the performers list, depending on where you are in England or where you want to practice, so that somebody knows that you are a GP in that area. And that's it. You're a GP now. And then we get to see you at what we call the new member ceremony. So next slide, please. The RCGP then brings you down to wherever you book yourself in. It could be London, it could be local to you. And you come and we announce your name, and your family come, we clap for you, and we celebrate the fact that you've gone through this however many years and you are now a GP. So that's what the training is all about. Yeah. And we look forward to seeing all of you at the other end, because we know that you can do this. You just have to make sure that you take on board what we've said and you prepare yourself very well and you do what you need to do when you need to do it. Thank you very much for listening to us.
Thank you very much. Thank you very much indeed, Onyinye and Henry, for, as usual, very illuminating presentation with lots of insights. I think I can see in the chat, I think there's a lot of appreciation for the information that you've shared. I know questions are still coming through. We finished slightly ahead of time. So please, guys, feel free to put in your questions for Henry and Onyinye. They are here. Anything burning around examinations, assessments, anything that you're not sure of, you want to clarify, this is the time. It sounds like a lot, but as they've both said, this information is contained in your e-portfolio. You can speak to both your educational supervisor, your clinical supervisors about these things. They've mentioned, I'm really pleased that Henry spoke on artificial intelligence and being careful about the use of artificial intelligence, especially at this time. Of course, he emphasized mandatory training, the importance of your reflective learning, and Onyinye was just talking about exams and costs. And so it's good to sort of think about these things ahead, so that you're careful how you're spending your money. Don't feel pressured. Don't feel pressured that you have to do this or you have to do that. There is a lot of support from the college, from your deanery, from your trainers with regards to these things. So I can see that the questions that are being covered, I think there's just one and somebody's responding to them. So I think at this point, if nobody has any burning question that they want to voice out loud, I'm just looking at the delegates screen. I think at this time, it's just left for me to say again, another very, very big thank you to Onyinye and Henry for giving up their time. I know you're devoted to this aspect of training and supporting registrars. I know it's a very deep passion of yours. So thank you so much for taking the time to support us with your presentations today. Thank you. So at this stage, I will hand over to Azza, because we're going to start on the next aspect of the presentation, arriving and settling into the UK. You can still continue to use the Q&A for any questions, and we shall be happy to address them. Thank you.
Thank you, Sylvia. And I can see also that there are some Q&A, well, questions popping up as well in the box. Please, I would really urge you to put your questions in the Q&A box rather than the chat. Your questions are valuable for us, and we are keen to answer them. So we don't want to miss them. So please just to try to use it, not the chat box. So we're going to start our presentation, this session, arriving and settling in the UK. So to start with, just to clarify the terminology of international medical graduate, there are certain categories. So there are international graduates who are don't have any, they just arrived to the UK or about to arrive for next week's start of the training, and they don't have any NHS experience. And there are others who are the IMGs who had some experience from the past, and some others are consultants and medical registrars or registrars and working here for years in the UK. And the third category that come to my mind as well is there's UK citizens that they had their primary medical qualification abroad and came back to the UK. So this is, I think, the first category, and the second may be useful for them, and especially the first category may be useful for them this session. Now, challenges that they will at arriving to the UK could be challenging, could be daunting. Lots of challenges with regards to if you arrive on your own, without your family. There are lots of other social and financial and professional. And for this session, we try to make it as easy as possible, and try to guide you and signpost to some resources as well. Next, please. So I'm going to start with the personal and family challenges. You might be just arrived on your own, and you are really missing your family. But before this, we just need you to set your mindset. I will succeed. I'm going to make it again and again the same. Reinforce the same information or the advice and tips that were given by the speakers earlier. Self-advocacy. Always ask. And have a list of jobs to do, and makes life easy for you. Once you have a real good start, it makes your training and your life gets smoother. So first of all, please just register with your GP practice and a dentist. You can Google, you can go into NHS UK website and find the nearest practice close by where you live, your accommodation. Secondly, and this is really important, occupational health department. Please just approach them, and if you have any medical condition, either physical, mental, you must I would advise you to approach them in case you need any amended duties, you need any adaptation to your place of work. Also to mention about what Henry and Oni had reinforced here is the any neurodiverse individual is not a stigma in the UK. Honestly, it's not a stigma. If you have any disability, well, in regards to, it's not, I wouldn't say disability, but any neurodiversity, we are highly function. We're very intelligent people. If you feel like you are dyslexic, you've been diagnosed or not diagnosed, and you think you are, please seek advice. If you suffer from ADHD, autism, please seek advice and seek help. at the start of the training, not leave it for too long, not leave it until you, touch wood, fail any exams, or being behind with your training, you can't finish on time, and even during your day-to-day work in hospital placements, that you are a little bit late, delayed, and because this will create stress and will burden on you. Don't forget to bring your vaccination status. Again, avoid any delays of starting your job. Well-being, really important. The social prescriber is a scheme that is available, I believe, across the country in lots of regions. So please search your training program websites to find out what is available and what's on offer in your area. The social prescriber scheme, they provide one-to-one advice in regards to mental health. They can do it face-to-face, they can do it online, on the phone, and please, again, reach out to your peers, whoever, peers at your workplace, peers who from your country that they came back, they arrived to UK before you, and ask at the start and make a list of what you would need to do at the start of your training. Network your community as well. We'll come into that next, please. Next slide, please. So there is here a video that we're going to play for 2 minutes, and then please just feel free to watch these sessions again as they are recorded. You will have opportunity to watch them again at a later date, and it will be just for a limited period. So yeah, please play it now, Giles.
There are quite a few differences in communications and the workplace that can lead to some miscommunication.
At the beginning, everything is new. You feel completely lost, and most of the people feel judged.
It's like going into a new hospital to do a locum job. Nothing is in the right place. You don't know who people are. You don't know who to ask. You don't know how to find the information you need. And then every encounter with a patient or a colleague is fraught with anxiety about communicating and misunderstanding.
The professional language and the language that they use to speak with patients, the language which is used amongst the colleagues, and the colloquial language is still something that I know that I'm not very confident at yet.
The greatest difference is patient safety, because when we do admission until discharge, we have this risk assessment. We have to check their diet, we have to check their nutrition, we have to check their BMI, we have to check the risk for falls. And in the Philippines, it's just like the basic necessities.
They've often come from cultures that are much more monocultural, and I think we're multicultural. And oddly, I think that is actually quite difficult for many of them, even more than just coming to a different culture, which is what they expect. Actually, what they're coming to is a melting pot.
Here you get to see like lots of different background, lots of different concepts, lots of values. So you have to deal each and every person differently, where back home you can just generalize everyone and just go with the flow.
Culture in our countries, we know the culture. We take some things for granted. We don't need to ask because we know. But if we extrapolate this to another country, another culture, it just doesn't work. Because especially London, there are people from almost everywhere in the world. And medicine is medicine everywhere. We have studied the same thing, the same diseases. But the way of interacting is completely different. And if we use the same for everybody, we are going to fail.
There's both your general culture, which you really pick up from your carers before you can talk, really. In terms of the things that are good and bad, how you relate to your seniors, what makes you feel better, what makes you feel worse. And that does vary in a very subtle way from culture to culture. And then on top of that, you've got 5 years of learning in medical school. and picking up not just a hidden curriculum, but the implicit curriculum, the things that people take for granted but never quite explain to you.
When they're trying to tell you something, they often will try to tell it in sometimes oblique way. They're trying to soften it. And that in the continent comes across as not coming straight to the point and not saying what you think, and as in a way hiding your true intentions, and sometimes leading to a complete communications failure where one thinks, oh, that went pretty well, and actually the person was the entire time trying to say quite negative things, but in a very nice way.
Normally people in my country, they expect the doctor to know everything, to have all the answers. They come to you, you have to sort out the problem. And if you hesitate or you try to ask them something else, or what do you think? And they will think like, why did you ask me? You are the doctor, you should know, come on.
For those who've trained outside of this country, it's quite difficult to adjust to some of our current thinking about trying to elicit patients' or parents' or families' concerns, and how really to organise their whole interview around that.
Here, the patient gives consent, but back in my country, for example, if it's a woman, the consent is either by parents or by husband or by brother. The other cultural difference I found very challenging is that we are taught directly, we are asked directly, we are questions just straight and forward and directly. Can you do this, or would you do this, or please do this? But here everything goes indirectly, because in the British culture, for example, I was standing with my consultant and she said, let's have a look at the abdominal x-ray, and I was just standing there until she opened the computer herself, and then I was so kind of, when you feel ashamed, and then I was like, okay, this is a difference in the culture that I need to be learning.
In Albania.
Thank you. I think we've gone beyond the 2 minutes, but I think it was really useful as well. And I'm so sorry that some of you couldn't watch the video, but they could hear it. This is from a video from the YouTube as well, so I hope you would be able to access. And also later on, when you watch the recording, you would be able to do so. So this is well covered the cultural changes that and the challenges that you can face here in the UK. Now, with regards to the families, some of you arrived on their own, they missed their own family, their loved ones, and some others are single parents, they brought their own kids with them and looking for full-time training as they wouldn't be able to work for or train and working long hours and in hospital placements, for example. Others are pregnant, waiting to start maternity leave. So with these occasions, well, it would be really important to seek advice, speak to your education supervisor, your training program director, and if you feel lonely, upset, I would say, not depressed, but just feeling overwhelmed with being on your own, please seek help from your own GP or the social prescriber if you could, or your network, your family. That would be great. Now, I'm just reinforcing again the value of the social prescribing. They're not only providing for you the help for your personalized care, it's also for your family. With regards to schooling, childcare, accommodation, they would be able to assist you. So please have a look at this website and see what's on offer in your area. Visa and immigration, if you are looking to bring your own kids or your loved ones, just have a look in there to find the updated visa guidance. There's also on the 25th of March a webinar by one of our IMG leaders, Navigate Your Path, a peer-led guide to the UK. It's a UK health worker visa webinar. We are going to share the link now. So this is another opportunity to ask questions, but however, it's not for any immigration guidance. If you need any immigration guidance, that would be through the website or through lawyers, through the usual channels. Next, please.
You can't.
Thank you. So, where to seek advice or request, well, ask questions or obtain information. The LAT is the Lead Employer Trust, and from our website as well, the RCGP. There's a number of resources in the final slides after my colleague Sylvia will speak, where it has a wealth of knowledge with regards to where we've got designated IMG website pages, as well as overseas guides. We also have a forum where you would find also some podcasts about the social prescribing and the other events, current events that will take, or current events or the future events that they are copying, and it's are upcoming. And it's also an opportunity for you to ask us questions in this forum. Family and friends, as we mentioned earlier, your education supervisor, your clinical supervisor, your training program director, the BMA, your colleagues, as we said, and peers. And with regards to these sort of terminologies, this is the NHS England. These are your the NIMDTA is the North Ireland Medical and Dental Training. The NES is the NHS Education for Scotland, and the HEIW is the Health Education and Improvement Wales. Next, please. Some other colleagues of us are IMGs as well, and I'm actually a member of at least two of these groups. They feel that they would like to have their own, try to be attached to, and it's really an excellent idea to attach to their own community where they come from, where they share some of their values and thoughts. And some of these organizations are having an excellent peer support, and also they organize events. So it might be worth it. And if you can't find any that belongs to you or where you're coming from, please just even Google or ask your friends, your peers, to be able to have this network, which is invaluable. They're invaluable now, and the local communities, I must admit. Next, please. So now over to Sylvia. Thank you.
Thank you. Thank you so much, Azza. And yes, please do keep your questions coming. I'm just going to take the last couple of slides for this presentation, where we are just trying to provide information for this particular aspect, where we're looking at financial suggestions and advice. I'm not a financial advisor. As a disclaimer, these are just things that we feel might be helpful and probably relevant to people who have not yet arrived in the UK, those who are still traveling down, not yet here. And again, the information might not be specific to your situation, but we just thought it might be helpful as a general guide. So the first thing there is about ensuring you have sufficient funds. That's if you're relocating. I can't tell you exactly how much is sufficient. Nobody can. You are the only person that can determine that. But the key thing is just to make sure that you think ahead. If you're coming by yourself or you're coming with dependents, that you have enough to manage your needs, whether it's for accommodation, food, and transport, and so on. So this will vary from person to person, but please to have this in mind, so that there's no extra pressure on you while you're trying to get used to the different culture, get used to training, or get used to so many different things, having to worry about money as well. We thought it would be useful to mention recurring bills and payments that will take up sizable income, and the list we have is not there can be so much more that can be put on this list. The word escapes my mind now, but we're just trying to think of things that would be useful so that you know that you're adequately prepared. So some of the things are your rent, mortgage payments. For those coming here for the very first time, looking for rent, especially if you're not staying with friends and family, you might be renting an Airbnb. There's some websites like Rightmove or Zoopla where you could find advertisements for short to long-term stay. Rent generally depends on your local area. It does vary from place to place. You might need to pay not just 1 month, you may need to pay 2 or 3 months in advance. It depends. It's really important that you're checking that where you're staying, your accommodation is not too far from work, especially if you're sort of fairly new, and so your work commute is not a big headache. So consider that when you're looking for somewhere to work. Key thing to check on the rent agreement, important little bits like if there's a notice period that you have to give before you leave, if there are any penalties and damages and so on, that might just be in the small print of your agreement. Please do pay attention to those. A mortgage is taking out a loan to buy a house. Some people might be able to do this. It may be a bit later on for others when you've established a credit history. But again, we would say consider the area, closeness to your place of work, to schools for the kids, close to hospitals, close to surgery, close to groceries, and shops and things like that. These are important things to keep in mind. Just a quick touch on transportation as well. The public transport system, very well organized, effective. Sometimes there might be a few hiccups, so it's good to plan in advance. We can't emphasize the importance of knowing how to commute to your place of work from where you live or from any other places really, and knowing that ahead of time so that the first day of work is not the first time you discover what the bus or train system is like, because sometimes there could be delays, there could be bad weather, there could be different things. And while this system works very well, normally some issues could happen. So good transport networks, there are websites or apps that you can use to plan your journey. It's about asking questions, about looking online, putting in your location to see what is the best way to get from where you are now to where you're going. You could think about driving license and lessons after you've settled a bit, and I'm speaking specifically to those who have not been living in the UK. So when you come over, you may get used to public transport, but perhaps after a few months or so, you can think about driving lessons and getting a driving license. The council tax refers to a compulsory tax that is taken by different local governments across the country, used to pay for local community services, taking away waste, libraries, police, and fire departments, transport. So it's a tax that every one of us or most of us will pay. The reason it's put here is just that you're familiar with whether or not it's included with your rent. And it's just, we're talking about this cost because we don't want you to be surprised. The big difference that in your rent agreement, be sure, be aware of what's happening. Is it being paid separately? So that's for utility bills like gas, electricity, water, and so on. Please check with your landlord. We put childcare here as well for those who have kids, so that you're looking for the different childcare and school options. There is the gov.uk website. I'll put the link as we finish this for people to look at options for parenting and childcare, things that you should know or you should be aware of, especially legal ramifications and different facilities. Some people may qualify for tax-free childcare. Like I said, I'll put the link so that you can take time and have a look at what is relevant. Other charges and costs that will be important to mention, depending on your situation, are things like home and car insurance. Very important are your professional fees, which can very quickly add up. I saw somebody mention about the exams being expensive. I will not disagree with you, but it is important that you're aware of these responsibilities so that they do not create any problems going forward. So refer to your subscriptions with the General Medical Council, the RCGP, the college, the British Medical Association. Some of them are taken as direct debits, quarterly direct debits or annual payments that you would make depending on which option that you select when you do open accounts or when you do join these different organizations. And finally, on this is to mention savings. And the reason it's put here is just to consider those who may be switching from a post, maybe a locum or non-training post, to ST training in general practice, to consider that there may be a small drop in salary or a change in salary as you start, and just useful for you to be aware of this, prepared for this, and have some savings set aside to make sure that your bills are covered. Can we move to the next slide, please? Thank you. So this is the professional work. And just to mention, please do put in your questions. Myself and Azza will hopefully be able to cover this, cover them at the end of the presentation. So this is professional membership, and I feel everybody else has talked about this, which is absolutely fine. I just want to reference that you will see these names that we mentioned here and there, and you think RCGP, GMC, BMA, MDU, what do they mean? How are they different? And you will get used to them with time. But just to say that the RCGP, the Royal College of General Practitioners, is your professional home as a general practitioner. It's where you belong. And we are responsible for patient care, setting clinical standards. We contribute to GP training in setting the curriculum, contribute to GP registration. We provide representation for our members, well-being support, career progression, professional development, and of course, as Onyinye said earlier, celebrating your wins, celebrating your achievements as you progress through the career. So right from this time as a trainee to the time that you finish and you become what we call the first five, you join those who have just finished VTS and are entering the first 5 years of practice, and beyond that to what we call mid-career GPs, and well beyond that to late career GPs. The college is very much invested and interested, providing support in terms of well-being, education, different activities that we are part of right from the time that you join the college. So this is the role. Different from the GMC, which stands for Good Medical Practice. You're very familiar with the GMC, of course, having taken the professional examinations. So they provide our professional license. They are our regulator. The GMC's job is to help to protect patients and improve medical education and practice in the United Kingdom. They set standards for both students and doctors, help us to achieve them. And when things do not go as planned or as well as they should, then they step in. So the GMC is available for information around medical registration, GP registration, becoming a doctor in the UK, providing ethical guidance, dealing with concerns and investigations into medical practice. They are our regulator. The British Medical Association, like Onyinye said, I believe it was Onyinye, you consider as your trade union, the doctors and medical students trade union. For information, so you can go to the BMA for information on pay and contracts. If you're starting a new job, for example, after you've completed training and you're not sure if what they're asking you to sign is standard for practicing doctors, if you're a member of the BMA, you can show them the contract and they can advise you. You just have to be a member. And you can also talk to them if there are complaints that you need advice about, and they can provide support for their members. You've heard us talk about MDU, MDDUS, MPS, the Medical Defense Union, the Medical Protection Society. So these are the medical indemnity organizations that we have in the United Kingdom. As practicing clinicians, even as a registrar, we are expected to have medical insurance cover. So you can pick an indemnity organization. I don't know if the reg reps are still here to correct me whether as part of your training there is some sort of special arrangement that you have. I'm not very sure. They might be able to speak to that. But they all provide similar cover. And it's important, it's mandatory really before you work in the United Kingdom, you must be a member of one of these organizations. Now, this afternoon, we do have a presentation from the MDU, so you will hear a lot more about what they do. Then we have Azza has just been mentioning them, the statutory education bodies in the United Kingdom, and there are different ones depending on which country, which of the nations that you're in. So for England, we have NHS England, who supports training and education of our healthcare workforce. And in Northern Ireland, we have the NIMDTA. These are education and training bodies responsible for developing and delivering healthcare education. Okay, so while I'm saying that at the RCGP, we look at your curriculum, and these education bodies plan your program. This is where your dean is allocated, where your training program director will get the details and the content that they're going to use to train, to provide your training or provide your specialty training. They're responsible for your training program, your rotations, your posts, providing educational support. So you will soon be meeting the people who are in charge of your training scheme. It's just important that you are aware that there are some differences between all these organizations. Please don't feel as if you need to know all of this straight off. Important that you know that they exist and that there are some slight differences, and with time you'll be familiar with what they mean. I think something else that's important that I wanted to comment on, I'm just having a look at the slide, is about planning and preparing. So, you know, it's useful if it's possible, if you've got the time, useful to think about a visit to your first place of work, or even as you change rotations or posts, just to visit ahead. I know it gets busy. So for example, if you're already in a busy hospital rotation, you may not be able to visit your next post. That's fine. But if you're starting and you've got some time, you're in the country, you've got some time, it might be worthwhile to plan ahead. You could think about your first day commute or your commute for the first week. Think about the possibility of traffic delays. Like I said, a very good travel network, but there could be delays. Buses or trains can get cancelled for one reason or the other. Leave good allowance for plan B. If you can arrive a bit early, half an hour, 10 minutes early, it makes a good impression with your educational supervisor or clinical supervisor. It can help you to just calm down, take stock of things. But if you're running late, like I always say, life happens. Something could just come up and you're not able to arrive on time. If that happens, the first thing after you've sort of gathered yourself, please call whoever you need to call, whoever is the first point of contact. In the surgery, it might be the receptionist, or if you have the number for the surgery, and ring and let somebody know, this is what's happened to me. I'm going to be there in the next hour, next 2 hours, or whatever. The worst thing to do is not to call anybody. The worst thing to do is for people to be saying, oh, where is Dr. So-and-so? Where is Dr. Sylvia? Isn't she supposed to be here? That's the worst thing to do, because it puts pressure on people. There may be patients that you're supposed to see. Everybody doesn't know where you are, and they can't say, oh, I'm so sorry, Dr. Sylvia has been delayed by so-and-so. Can we reschedule? Can we book? So just think ahead about the things that will be really useful. I was also going to talk about popping in to see maybe your clinical supervisor or educational supervisor, just to get to know where the department is, get to know people in the practice. It is possible if you give them a ring, if they've got accommodation for that, they might be able to just come in and just look around where you're going to be starting your work with. There's also the bit about rotas, especially so please consider these things well ahead of time. Book them early so that you're not, disappointed when you need to be somewhere. I know it can be tricky. I appreciate that, but just be aware. It can vary from place to place, but just to say that you do have access to study leave. So find out what is going on. Your TPD, your training program director, your educational supervisor, clinical supervisor, your registrar, your GP registrar reps, these are all fountains of knowledge for this thing. So please don't be isolated in terms of the information that you might need. And then a quick word about mentoring, really important, about having a mentor. The RCGP has a mentoring group, mentoring forum. So it's something that you can join. The link again will be shared with you. But also from social networks, attend events that we put out. We have events for international medical graduates. For example, I'm also the chair of the International Medical Graduates Special Interest Group, which is an informal community of individuals, GPs that have similar interests. And if this is an area that you're interested in joining, you're welcome to look on the website and, you look at how to join. The other thing is that there's so many different special interest groups. I know some people were talking about getting involved in different areas of special interest, or as we call them, extended roles. One of the ways that you could start to hear about what's going on is if you join the area of interest. So women's health, I think we've got one. We've got health inequalities. We've got quite a few. And again, there is a page on our website that is devoted to information about them. So an invitation to attend events, keep an eye out if you can. I know it's busy. I know the life of a registrar, I know it's busy, but if you can, it's a good way to meet your local faculty boards. Come and meet people like myself, Azza, your GP Reg representatives, the IMG leads of your different faculties. Every faculty has an IMG representative. So these are different individuals or different roles that you can know about. Get in touch with us. If you don't know who your faculty is, I have a link for the RCGP faculties. You can find where is your location. If you want to know more about the faculty or come to a faculty board meeting, you can contact the faculty administrator. Their emails will be on the website, and they're usually very, very good at responding. Can I go on to slide 9, please? And that is that's the last slide where we have useful links. I'm going to share them, like I said. And so this is the point where I close on the presentation, and things are now open for us to have a conversation. Myself and Azza are happy to take any questions. Of course, we don't know everything, but please feel free to ask anything that you're not sure about. We will either tell you what we know or point you in the right direction. And of course, there are lots of colleagues in the background. I don't know if we've had any visitors like the chairs of the devolved nations, as I don't know if anybody has popped on. I know that our chair for Scotland tends to pop in sometimes to say hi to his new registrars. I don't know if he's had time today. So
I don't actually. I can't see the names.
Okay. Yes, I know.
So my apology. So please let us know if there is any college officers around, please, event team, so we can give them opportunity to speak as well.
Thank you. So let's go into questions now. I'm just going to put in the chat some links, as I don't know if you're on top of any of the questions while
so I'm just there is a question by can you just go back again? I think it's been answered. Okay, so I'm going to go from the top to the bottom. So we've got Abraham asked, thank you so much for all the wonderful information so far. Please, it was mentioned earlier that we can get social support. Can our spouse, who are also professionals and currently unemployed, be supported too through this relocation? So can I just ask, please, is it just a social support you are after? If you can just clarify if that is the case, Abraham. Again, if you can try to search a network around you, try to approach your colleagues, perhaps from different communities, from your same community, and see what's her interest, whether she would like to start her requalification or start her exams here for entry to work in the UK, or any other learning opportunity for her, or even hobbies. That would be really my advice. It depends on the locality and where you are. And please reach out to your faculty IMG rep, because this is where you will find your own IMG community as well. I hope I've answered your questions. Then we've got, please can you drop the link to joining the group? Yes, thank you. I believe the Sylvia, I think you have shared the link. Or
yeah, I've been putting
shared the link. Yes, she did.
Yeah, I've been putting a few on. I hope I don't miss any out.
Yeah, thank you. Thanks so much. Now, thank you, Alexandra, again, Abraham, plus him. Thank you, Alexandra, for mentioning the special interest. I am quite interested in surgery, if that's possible, as a GP. I know it's probably minor surgery, but that's okay. Yes, absolutely. And there are some courses as well that available events through the college and wider accredited events for minor surgery. However, I'm not quite sure, and I believe Dr. Henry and Dr. Okonkwo had mentioned about the special interest and whether this would count to start any qualifications alongside your GP training. But by all means, I think it would be best if you can discuss it with your own clinical supervisor, your training program director in your region, to see what's on offer in there and whether you would be able to do them and sit these exams, if there is any exam. Otherwise, minor surgeries, by all means, so after graduation, you can set up your own clinic, or the clinics through your contract with your practice that you would be working through. I hope I answered your question, Bram. Next, we've got Oluwamisi. Apologize, I'm not very good with pronouncing names, but Alexandra is answering. Please, how can we join the RCGP? I saw there was one of the requirements to have registered with the GMC for at least 5 years. Is that right? I think you will be able to join the RCGP. It's part of your induction. There would be a list, and I believe I'm not the expert, but we are, if I correctly recall from my training days, we have a registration, and Alex and Eman can correct me. We have an application to be able to apply at the start of the training and have a training number. So correct me, Eman and Shamsaee, if I'm wrong, please. Thank you. Oh, Shamsaee, Eman, yeah, go ahead, please, Eman.
Yeah, so usually as part of your training, you will need to be a member of the RCGP because your entire portfolio will actually be through the RCGP. So the entire portfolio is through that. So usually when you come onto your GP training, there's usually a welcome email. They onboard you, which basically is a fancy word of saying that they're going to register you as part of a member, and then you're part of this cool selected club where you can come to all of our events as well, which is really exciting.
Thank you, Eman. This is what I alluded to when I said induction pack or induction. So thank you so much. Now, do you want Sylvia to answer any? Sorry, I'm just taking over all.
No,
Go ahead,
that's
please,
fine.
if there is any questions.
Please zip along. Okay, let me.
Right. So
let me see.
Yeah.
Yeah, there's one at the top. Let me just give your voice a spell. I'll just take this one at the top. I don't know if anybody's so this is from Abraham, who says, thank you so much for all the wonderful information. It was mentioned earlier that we can get social support. Can our spouse, who are also professionals and currently unemployed, be supported through this relocation process? Thank you, Abraham, for the question. I'll ask Eman or Alex if they're still here to contribute as well. To my knowledge, when we say social support, we're talking about the member well-being. So it's really in reference to yourself as the member. To my knowledge, we don't provide any sort of financial support to dependents or relatives coming in with you. So it's really about yourself. And Eman, I don't know if you're able to comment on that. I mean, you have experience in that sense. If you have any information to add to that. Or Alex is here as well.
Yeah, of course. I know within Hull in particular, and I believe it's in Yorkshire, there is a social support team actually. So when you come on your IMG induction scheme, sometimes there is someone who can provide that social support to say, you know what, which homes are available, how do you go through the housing process, how do you go, and they signpost you to things. But just as Sylvia has also mentioned, it's not necessarily that there's a necessary bursary that I'm aware of that's given or anything like that. It's more, so there's no monetary sort of funding in that way from my understanding. It's more just signposting you to the right people. If you're confused about how to get driving lessons or organized bank accounts or schooling systems, anything like that, at least it's a point of call that you can go through. And hypothetically, if you didn't have that social support within your GP training scheme, then that is still potentially available through even your GP practices sometimes on occasion as well, which is something for me just to mention. I don't know if Alex, you had anything else to add to that.
Yeah, I was only coming to say about the social prescribing schemes as well, which obviously we have in Yorkshire, but it might not be everywhere. But I think they are kind of most schemes now, aren't they? And I know in Yorkshire that they do offer those services to family members as well as trainees on the programme. So that might be something to explore with social prescribing.
Yeah, thank you both. So it looks like there might be something you have to ask specifically for your area. I mean, think about the different localities. So there might be one experience for you, but please don't be shy. Do ask. I don't know what happens in somewhere like, London or some of the southern faculties. I've been a northern person for such a long time. So there may be some provisions and it's good to ask. Don't forget what, we've said at the beginning. Don't be afraid to ask for something if you're not sure. Let me just take this one I've just seen and then I'll pass it back to you. Azza. Somebody says, it's Ebolua says, what is the ideal time to apply for leave in a rotation? If you have to take your leave in the early part of your next posting, how do you go about it? So I think a good question, because we just talked about planning. And if you know your rotation already, then you can get in touch with them ahead of time. It means that if you're in general practice and you know that in the next 2 months or next 1.5 months, or you're starting medicine, for example, you can get in touch with the people in that area. You can get in touch with HR or whoever is in charge. Your rota is already provided to you and say to them, can I get leave for this period of time? So it is possible to ask them this question and they can provide it early in the rotation. Planning is always important. And again, Alex and Eman, please feel free to pop in if there's anything that you think would be useful to add. Azza, I'll hand it back to you.
I was just going to say, with regards to leave, I totally agree. Trying to getting in early is so much better. So if you can be planned and think, oh, you know what, I want to plan a holiday for this point, I want to plan a holiday for that. Really important to try and get that leave put in earlier, just to make sure that you're able to get it from that a bit, or at least there are less issues. I think in most places you do need to give some element of notice. This does change depending on which hospital trust you're working in or which GP practice you're working in as well. So do check within whichever local places you are in. I think on average it tends to be minimum of about 2 months or so on, roughly, but it does vary.
Yeah, I would agree with you, Sylvia and Eman, and I believe, correct me if I'm wrong, it's about at least 6 weeks, at least as far as I remember. And especially it's really important. Remember that you've got a rotation, you work in a team, especially in hospitals during on calls, and if we think about Christmas time or Eid time or any other religious, they will be all, if all the team are from the same sort of faith, then it's going to be difficult. So it's really important. And also what is really important, if you find that other colleagues of you have, well, applied for the same timings or dates, it might be really useful to try to negotiate and speak to them just to see if will be helpful. Because remember, if you take holiday at the start of your training, for example, for a week, and other colleagues, you might need to cover them as well. So it's going to pay off somehow as a peer support, which works really well. Over to you, Alex.
I was just going to say about annual leave. It's good to look at the annual leave policy for your organisation, because you'll be employed by an employing trust, and just try to follow their policy. When you are in GP, it's slightly different because there is a little bit more flexibility, and lots of places might require you to give less notice. So, for example, at my last practice, there was only kind of a requirement for 4 weeks notice. That's obviously different from the policy. But if you do follow the policy, so for example, 6 to 8 weeks notice, and you give that notice that's required, in primary care, you're actually classed as supernumerary in your contract. So you shouldn't be having annual leave requests declined. If you give enough notice in primary care, that shouldn't be happening. In the hospital rotations, it can be slightly trickier to negotiate leave. But again, you shouldn't be having requests declined if you're following the policy, except in exceptional circumstances. And if you are having annual leave requests declined and struggling to take leave, as I know some registrars have been in some hospital rotations, please reach out to your reps and your TPDs so that they can help you navigate that situation.
Thank you, Alex. We've got a question. How can we know who's our supervisor, as a medical supervisor or clinical supervisor? I think, as Eman mentioned earlier, there would be communication sent out and it would have all these details. So rest assured, you will receive it very soon. Can you kindly shed more light on the study leave? Again, I think this is, if you can discuss it with your education supervisor, training program director, and I think it would follow again all the policies of the trust that you work with, as well as your training program, because they would need in this occasion to sign, and especially if you are going to attend an educational course, a learning event or a course for a few days, that needs approval as well in advance. And you will be entitled, I believe, to commute, for the travel as well as meals, something of those kinds. It will be all on the forms that you will be it probably would be accessible. As far as I know, they are accessible in your own training program sites. Thank you. I think we're pretty much finished. So over to you, Sylvia. All the questions, we completed them.
Lovely. Yes, thank you. Questions can come throughout the day. Please keep bringing the questions. There are a couple more. So I'm going to try and bring things to a close in about 4 minutes or so. We've got 4 minutes before we will need to start getting things rounded up. So somebody's saying here, Alex is typing, but let me read it out. And then regarding the leave, one of the presenters mentioned that after 10 days of leave, the training program need to be notified. If that point can be clarified, that would be great. Alex, would you want to come on board and speak onto this one? I'm not sure. I didn't hear this. I must have missed it. Alex, thank you. So good that you're here.
Sorry, I was just typing and then I stopped typing when you started talking. I think if you're talking about annual leave or study leave, you don't need to notify your training scheme about your annual leave. That's just with you and your rotation. So you and the rota coordinator would have that conversation. In terms of study leave, obviously that does, as we just said, that there are various forms involved in that process. So it will involve applying for leave with the rota coordinator, but also applying through the process with your TPDs via the forms to make sure that course is approved for you and access the funding for that. I don't know about the 10 days. I don't know if that's maybe if you're talking about time out of training instead of annual leave. I don't know if that's
I'm not
maybe
sure. Yeah.
But for leave, you just follow the policies, and there's no requirement to inform your scheme about over 10 days of leave, as far as I'm aware.
Thank you so much, Alex. Yeah, if the person who asked the question, if you wanted to clarify that, please do feel free to do so. So we've got Hanin who's asking about audits and says, doing them in my country before applying to GP training, would they be helpful strengthening my CV and improving chances getting a job as a trainee, or audits should be only in UK hospitals? I think the quick answer to that is it's really regarding experience and work in the United Kingdom. The audits that you do outside the country, of course, they're valuable, but they'll be limited to a different type of healthcare system. So we're looking at audits that you're carrying out in practice, because don't forget, it's not just doing the audits. It's important that there are things that can be applied in practice. Audits are supposed to help us to improve practice. So one of the things about an audit is after you've done the first cycle, you go back and you've done the first cycle and you've put in the bits and pieces that we need to change in practice. You may come back after a year and do a re-audit. So it's really within the system, within the UK, that we expect those audits to help and strengthen your CV. Thank you for that question. So someone says, Ebube, I'm sorry when I say someone, I'm just going straight into your question. I mean no offense. But Ebube Chukwu says, please, are we going to get reimbursement for transport for training teachings that we attend, like trains and bus cost? Now, I remember in my own time that we did have this form that we used to fill for reimbursement, but let me get Alex and Eman, the experts, to handle this question for me. Who wants to come in? Thank you.
So I know that in certain training schemes, you should be able to have basically what they're called expenses forms. And on some occasions, for certain courses that maybe you attend, or for example, if you're having to do, especially like, for example, in GP practices, if you're going on lots of home visits, for example, and you're going from one place to another place to another place, it is possible, and depending on which area, to potentially apply for expenses leave and expenses and get some of that money claimed back. It will vary from different GP training schemes. So I would say to liaise with your own local scheme, your TPDs, maybe, especially when it comes to your inductions, more locally, they'll probably explain more information regarding that. But it is sometimes a thing that with regards to trains, buses, you might be able to get a certain amount off of that back for certain specific educational things that you may have to attend. I don't know if Alex wanted to add anything further to that.
Oh, sorry, I was looking at a different question. Yeah, in terms of travel reimbursement, you should be able to claim expenses for travel as per the sort of overall resident doctor contract in terms and conditions. There is a page in the BMA GP Registrar handbook. So if you Google BMA GP Registrar handbook, you'll find that document, and then that has a bit more information about travel expenses. I do think it's not always explained that well in some of these documents. So it is worth contacting your scheme specifically. So, but you can claim that. You just need to go through the complicated process of setting that up.
Thank you. Thank you both. So we're going to keep it down to just one more question live, that is, because they will be answered. In fact, we have time. No, I don't think we do. I'm going to leave my colleague to answer all the questions because our next speaker is here. So I don't want to run the risk of us being very late for lunch. So I'm very, very grateful to Azza, Eman, Alex, and everybody else, because you've seen Viviani and Amy, everybody helping to answer the questions. So they will respond to your questions. But I think we will just close this arriving and settling in the UK segment. We'll just close it live now, and then my colleagues will focus on the questions while we move on to the very next aspect of the program. So at this point, I'm very, very pleased to welcome Jonathan Blay, who is the college, the RCGP Head of Campaigns and Public Affairs, to provide us with a brief update on an issue that you may be aware of, especially if you're in country, but that all of us have been following with very great interest as the bill has progressed or proceeded through Parliament in the last week. It's called the new Medical Training Prioritisation Bill, which will bring changes to medical recruitment and training from this year. So some changes from what we know. So welcome, Jonathan, and thank you so much for taking the time to be here today. I know we've given you about 10 minutes to talk, and you've promised to take some questions, but it's really good to see you. Thank you for joining us.
Thanks. Thank you, Sylvia. Yes, very happy to be here. Yeah, as Sylvia said, I'm Jonathan Blay. I'm Head of Campaigns and Public Affairs here at the college. So that means I'm not a doctor, but my role is to work for the GPs to sort of amplify their voices when it comes to politicians and political decision makers. I mean, to be clear, sort of, the role of the college, we don't set the rules for how general practice works. That's done by politicians and the Department of Health, or how immigration policy works. That's done by the Home Office. But my role is to make sure that those people who do set the rules actually hear the voices of those on the front line and get the strongest views of what's been going on. For a long time, one of the biggest issues that I've been raised by members is regarding visa issues connected to international medical graduates, especially on the point of when they qualify. If we look at other medical specialities, they have 5-year training courses, so it's easier to get indefinite leave to remain at the end of a training course. Unfortunately, that's not quite the same for general practice. With a 3-year course, means it has been a struggle. We've done a lot of work on this. We've done surveys of members, surveys of practices. We've been putting a lot of evidence through to governments on this issue. It's particularly live at the moment because the government are currently separate from this bill, considering rules around indefinite leave to remain. So we are pushing quite strongly along those lines of that. We have been doing this for a number of years. A few years ago, we managed to get a 4-month visa extension for GP trainees. It was a particularly difficult thing to do. The Home Office are not the easiest department to lobby, but we did have some success on that. But we're not resting on laurels. We're trying to push for indefinite leave to remain once GPs have completed specialist training. So that takes me to what I'm meant to be talking about today, specifically the Medical Prioritisation Training Bill. This was an emergency piece of legislation being introduced by the government. So it's not something that the college specifically were asking for, but it's something that we needed to respond to very quickly. The bill, I'm not sure how people are how much aware of this. The bill is going to change how prioritisation is managed for people going into medical training within the UK. I'm going to set out sort of the details about it. I'm happy to set out the details about it. I'm sure people will be interested as we go. But the general idea of it is that it's to prioritise those who are UK medical graduates to move into training. This was something set out in the government's 10-year health plan, that they were saying that they had concerns that there were that the UK government was training up a significant number of UK medical graduates who were unable to get training places within medicine because of competition from international medical graduates. So the college talked to members about this, and we raised significant concerns that the tone of this bill and the image it set didn't want to suggest that the UK was not welcoming to international medical graduates. The general practice has roughly 50% of all our trainees are international medical graduates. And we wanted to be very clear that the NHS still welcomes international graduates, and they play an incredibly important role in the future and in the current of the NHS. We therefore have been briefing politicians around this one, and we thought this would be a useful hook for our general policy on the fact that there needs to be indefinite leave to remain for people who qualify as GPs who've come to the UK internationally. So we've been using that. We were trying to get MPs to table amendments on that line. We were unfortunately not successful. This is largely because of how this bill is going through. Most bills take months to go through Parliament. This one is being pushed through in the Commons in one day, which was yesterday, and it will be pushed through in the Lords in one day, possibly next week. So we're having to react very quickly on this one. We did, however, manage to brief a number of MPs on this one, and a number of them spoke during the parliamentary debate yesterday, raised concerns that we had put to them regarding how this bill might be seen to be putting off international medical graduates and how the government needs to do more to support them, with one MP specifically raising around the issue about need to look at the indefinite leave to remain and where that sits with that. So I know Wes Streeting, the Secretary of State for Health, wasn't particularly supportive. He was talking about that being an issue for the Home Office, but was supportive about the general thing about needing to demonstrate to international medical graduates that they are still welcome in the NHS, even if the government is changing the prioritisation for these roles. I don't know how much people want to go into details of what the actual legislation says, but we are expecting it would be implemented in time for this year's group joining specialist training. So it's a very much a live issue. As I understand it, the bill for this year will be having prioritisation for UK medical graduates or those who have settled immigration status within the UK, as I understand it, but I'm just working out the exact. I need to get the exact wording right. I can put that in the chat exactly what the wording is, and I'll share the briefings and information with those in the chat so people can see what has been published by the government on this. And that next year that they would have prioritisation for those who are UK graduates and those who have significant experience within the NHS. They haven't yet determined how they determine significant experience within the NHS, and they've said that this year that's why they're going to use visa status as a proxy for this. So that's how they are currently thinking, and that's how it's going to be implemented. So that is the very basic gist of it and the work that the college has been doing on it. We are continuing to lobby around these issues. As I said, it's being rushed through Parliament. We're having much less time than we normally would. It's something we will raise with ministers, and it's something that we will be pushing to being raised in the House of Lords as the bill goes through. I'll just leave it there. That's probably best to open up so I can take questions on these ones. Very happy to respond.
Yes, thank you so much for that, Jonathan. Thank you for the update. So we've got a couple of questions that I'd like us to take if possible. And we've only got 3 minutes before we need to round up, but I think you've given a really good overview. The first question, someone says, as the new policy rolling out in the UK NHS is giving priority to train more local doctors over IMGs, how does it affect IMGs in securing a training position in the UK? And it relates to the next question from Shamsaee, who says, will this bill affect IMGs to find a job after completing GP training? So I'll just let you, Jonathan, just comment to this, please.
So no, I think this is about selection for training. So this bill would not affect those who are already been selected for training, and it would not affect those. So I think, so if you're selected for as I understand it, and I will need to get this information right, if you are in foundation training, it would not affect you because then you would be a prioritised group for specialist training. And if you're in specialist training, it would not affect you because you've already been selected for specialist training, so it's not at the selection point. It would not affect anyone once they have completed training. This is part of what the reassurances we were looking for from government, that they wanted to still say that they will very much value international medical graduates. I might just add one point. I didn't add this in, but as I said, there's about 50% of all trainees in general practice are international medical graduates. According to the information shared from the government, about 2,000 UK graduates, UK medical trained graduates, do not secure a place in any form of medical practice. So therefore, there will always need to be international medical graduates in that, because there's not that many spare UK medical graduates to fill up all the training places that there are. So there will always be a need for, it does seem like, unless medical schools are massively expanded, there will still always be a need for international medical graduates to apply. The government does have a power to sort of pause this if some specialities were not filling up their training places, and if they felt it was just putting people off from applying for UK everything. I thought I'd just add that a little bit of extra information in.
Excellent. Thank you so much, Jonathan. We've come to 20 minutes to 2, which is our lunch time. But I just want to add to what Jonathan's been saying, and the RCGP has been doing a lot of work to advocate for the issue regarding visas, which is one of the current things around getting work after training. So a lot of work is being done and will continue to be done. I noticed, I was just having a quick glance at the conversations and the statements from Parliament yesterday about there was a lot of commentary regarding the value of the work and the contributions that international medical graduates have made. So we will continue to work on this. RCGP as an organization is very mindful of the impact it's having on our trainees, and we will give our members updates as we get them. So thank you so much, Jonathan. Really appreciate your time coming to explain this to us and taking these questions. I think if any more, we'll be able to address them in the Q&A box during lunch. So thank you, everybody. We've now come to lunch. I've taken 1 minute away from your meal. I apologize, but we would love you to be back with us at, let me just have a quick look. Where is the agenda? Can someone help me? Azza, what time do we get back?
It's 2:10, please. If you can come back for the start of 2:15.
All right, lovely. So 2:15, everybody back. So see you shortly. And thank you so much for all your engagement this morning. Right, okay, welcome back from lunch, everybody. We're pleased that you're finding the session useful. Thank you so much for your comments, questions as well. Now, this part of the induction is devoted to two very important aspects of our work as registrars and GPs. Now, you might recall a lot of speakers had talked about medical indemnity and GMC in the morning. So we will shortly be hearing from one of the medical indemnity organizations, followed by a presentation from the GMC after that. And I'm pleased to let you know that our new RCGP chair, Professor Victoria Tzortziou Brown, will be joining us for closing remarks, and happy to take your questions at that stage. So things to look forward to. Now, let me mention right now that we will be sharing feedback forms close to the end of this event. So please don't rush away. Please help us complete them, so that we know what we can do to keep offering useful sessions like this at future events. So without further delay, I'd like to welcome our very next speaker, Chris Hall. Chris is the MDU's primary care liaison for the Northwest. The MDU is the Medical Defence Union and is the UK's leading medical defence organisation. Chris's role includes providing educational seminars to support GP trainees and practices in managing the day-to-day challenges of the profession. So I'm going to stop talking and let Chris tell you all about his work and the MDU. Thank you, Chris. Welcome.
Thank you, Sylvia. Thank you. And great to see so many of you here. And just offer, again, my congratulations to you all for getting to this point. It's really good. I've been doing this now, supporting this event for the last year or so, and it's really good to be involved. So yeah, just a little bit of background. Sylvia did a beautiful introduction there. Just a little bit about the MDU. So the MDU is the Medical Defence Union. We're what's called we're a member-based defence organisation. We were established in 1885, so we're in our 141st year. So we've been around a little bit. And our members essentially can contact us for advice and support with a range of medico-legal issues. So these are things like when an adverse incident may happen in practice in your clinical work, you can call us for advice. We can help you to respond to complaints from patients. We also get involved in representing and assisting members at the GMC as well. And things like helping to write reports to the coroner or attending an inquest as well. So all of those sort of medico-legal kind of things really that we can sort of support you through, because they can be a minefield and they're not the sorts of things that you come across every day. So someone helping you to navigate them can be really beneficial. And also when you call us and get advice and support, you always speak to a fellow doctor as well, which we think is really important because they're people that have walked in your shoes. So you always get sort of good support that way. So the talk I'm going to do, we've just got sort of 45 minutes or so. So we haven't got lots of time, and obviously the medico-legal side of things is quite a big area to cover. So I've picked out about 3 scenarios for us to just sort of work through. which just give you a sort of an idea of where things can sometimes go wrong, the types of things that our members call us about, and how things can be resolved with the correct action being taken. So yeah, we're going to highlight some of the common pitfalls that lie in medicine from a medical legal point of view. We're going to draw on guidance from bodies like the GMC and Department of Health and our own guidance. And hopefully overall, this will just give you a bit of confidence that when something does go wrong, and unfortunately, it's almost inevitable that something will go wrong at some point. You know, it might be quite minor, it might be more serious. That you've got a lot of support available to you, and it will give you a bit of confidence in resolving that as best as we can. So the scenarios that I've brought up for us to have a look at, which I just thought would be useful. So we've got a couple on consent and confidentiality as well, which are very common themes that we see in member queries that we get. They're very common themes also in complaints and other issues where there's been breakdown in confidentiality, breaches of confidentiality, where informed valid consent hasn't been gotten. So and that can result in complaints, and complaints are fairly common. So I thought, well, another good thing for me to have a look at for you is just kind of having a good approach to complaints, so that it's hopefully not too daunting if ever you do receive a complaint in the future. So I thought we'd have a look at those, and then we'll have a quick look at sort of indemnity in general, and deal with any sort of queries that you might have as well in regards to that, because I know it's come up in the past. So first and foremost, consent and confidentiality. So this is the first scenario that I thought we could have a look at. If you just want to take a minute just to have a read of this one and digest it. Okay, so we've got a really unfortunate situation here where this individual has stored lots of confidential information onto their laptop, and then through no fault of their own, they've been broken into and the laptop has been stolen. So, questions for discussion. And these are just things that, you know, we can sort of think about in terms of how this might progress. So could the doctor be criticised for the way that he handled the information? I think, yes, he could. Because of, you know, the issues around confidentiality, around consent, and also around data storage. So what might happen? There's likely that there would be some form of an investigation and possibly some form of disciplinary action, and potential referral to the GMC as well, because it is quite a serious situation. How should he respond now? So our advice would be that he puts himself in a position to understand the relevant guidance, and therefore to understand what he perhaps should have done differently. So, you know, we always advise members to be seen to be learning from when something's gone wrong, and also apologise for what went wrong. And I think this sort of approach is showing really good insight and remediation. And that's always a much better way to protect your medical legal position than adopting a more sort of defensive or confrontational approach when something goes wrong. So we would always advise that if you can show that insight and remediation, that's a really big plus for you. And I've got some useful information later on about the benefits of that, particularly in relation to the GMC. So also, yeah, so how should he, so yeah, when collating and storing data, what should you bear in mind? So I think just thinking about the GMC guidance on this, and also thinking about any organisation policies. So the practice that you work out, the trust that you work out, what are the policies are you keeping to within those policies? It's also worth bearing in mind that there is specific guidance on the storing and sharing and using of medical images as well. So there's some good GMC guidance on that area if ever you need to look at it. So just moving on. So yeah, the issues are that it is a breach of the General Data Protection Regulation. So there could be action by the ICO, which is the Information Commissioner's Office. It also could be a breach of policies from the trust. So the trust would be the data controller here and would report the data loss. So the trust could therefore face action. An example that I heard about as well of another one where the ICO was involved was a Welsh hospital where a consultant psychiatrist was cycling on his way home from work one day, and he had a bag on the back of his bike which fell off his bike. He didn't realise, and the bag contained some identifiable information related to a patient, and it also contained 5 CVs from doctors that were applying for jobs at the trust as well. So again, just another sort of inadvertent but fairly serious breach there. And then, of course, you know, it would be a breach of GMC guidance as well. So speaking of which, apologies, this is a bit sort of word heavy, but it just highlights the GMC guidance on the consenting process for making any sort of recordings with patient data. So obtaining consents for these sorts of things is fairly case specific, and it depends on why the recording is being made and for how long it will be kept and how long it will be stored for. And obviously patients can withhold and withdraw consents for that at any point, and they should do that without any fear that that would affect, you know, the care that they would receive. So just going back to this particular scenario of the stolen laptop, just have a think about what the doctor could do. You know, if you were in that position, how could you demonstrate that insight and remediation that we talked about earlier? So how could you demonstrate that, you know, you've recognized that something's gone wrong and that you're going to do something about it to ensure that it doesn't happen again? And just to further highlight that point, as mentioned, this was a study done by the GMC a few years ago now. And they looked at 147 cases that went to a tribunal hearing. And so that's normally, you know, the sort of final stage in the GMC where there's normally serious concerns about a doctor's fitness to practice. And what they saw was that out of those 147 cases, those that did show that insight, that showed awareness that something had gone wrong, that they'd tried to put things in place to ensure it didn't happen again, only 5% of those doctors were actually erased from the register. Whereas those that didn't show any insight and were perhaps more, confrontational, more defensive in their approach and didn't show that insight and remediation, well over half of them were actually erased. So I think it just really highlights the importance of that. And, you know, I heard a speaker mention about, you know, making reflective notes and things like that for your e-portfolios. Things like that all demonstrate this sort of insight that we're talking about. So it's really important to obviously to do that. So just some suggestions on this particular situation. So yeah, have a reflective discussion with your supervisor. You could speak to your TPD in this situation, make a reflective note, familiarize yourself with the guidance, the GMC guidance and any trust policies, maybe do some further learning. So things like e-modules as well. And also, you know, don't be wary of saying sorry. You know, if you feel that something could have been done better, say so. Be open and honest when things go wrong. And apologizing in no way makes you sort of negligent. You know, sometimes people can be a little bit twitchy about apologizing because they feel that, gosh, if I've apologized, I'm admitting some form of negligence or liability. Actually, that is protected under the Compensation Act, that's not the case. And an apology is often a really effective tool at diffusing situations and resolving issues with unhappy patients. So the outcome of this particular scenario was that they spoke to the MDU advisor, and they informed, and then the doctor informed their clinical governance team, and there was a disciplinary investigation. They had that reflective discussion with their supervisor. They refreshed themselves on the guidance, and also wrote a comprehensive reflective document as well. And as a result, the trust wrote to the patients, offering a sincere apology, and also informed the ICO, which would be standard. And the doctor was given a formal written warning by the trust because of the seriousness of the breach. It was referred to the GMC, but because of all the actions that the doctor had taken since the incident, the GMC reviewed that, and they were satisfied that they'd done what they needed to do, so they closed the case with no further action. So actually, that was a pretty good, result for that particular individual. So that was one on confidentiality with a bit of sort of consent in there as well. And then I've got one just specifically on consent, which I thought might be helpful. If we want to just have a read of this. Okay, so you've got a patient here who really just doesn't seem to want to have any information about any of the treatments. And, I'm getting a few sort of wry smiles from certainly from Sylvia, because I'm sure, they've had these sorts of patients and these sorts of situations before. And it's just, again, this is just to get you thinking about what you need to consider here. And I don't think it should be underestimated, actually, how often this happens, particularly maybe with older patients, where perhaps they're used to a bit more of a paternal approach, where they just want to be told, what's going to happen. So let's have a look then at consent and sort of definitions of consent. So this is the Department of Health definition. And I think one of the key bits of this definition is that term sort of voluntary and continuing, because sometimes you need to reobtain consent during the course of treatments. You may get consent at the outset, but then, if you feel that circumstances are changing, maybe the treatment is changing, consent is an ongoing process that you need to keep checking and keep recording that. And of course, consent can only be valid when it's been given without any sort of undue pressure or coercion as well. So people have got a free choice. And just a bit of background, I suppose, in terms of why consent is important. I mean, I know it's probably fairly obvious, but it's all part of providing good clinical care to the patients. It's based on the ethical principle of autonomy or self-determination, which essentially is that human beings have the right to decide what happens to their own bodies. It's a legal requirement, and it's a GMC expectation as well. And then for consent to actually then be valid, because sometimes, people might say, well, look, they gave me their permission, I've therefore got their consent. But actually, is that proper, informed and valid consent? And it can only be if these three requirements are met. So consent can only be valid if the patient has capacity. So that's essentially the mental, wherewithal to be able to weigh up the information, to make an informed decision and understand the pros and cons and be able to retain the information. They also have to provide consent freely, as said, so without being coerced or pressured by anyone else, either you or a family member or a friend or whoever it may be. And it has to be informed. So they have to have all of the information necessary to make a decision, don't they? So an explanation, which is communicated in a way that they're going to be able to understand. So not using technical language if you know they're not going to understand it. And then things like the nature, the purpose, and the risks of the proposed procedure. And it's really important to try and record as much as you can in the patient records this sort of consenting process, just in case that's ever called into question, later down the line in the form of a complaint or another issue. So outcome. So as we discussed at the beginning, consent is not valid if the information needed to make it is not understood. So I think, if that patient doesn't understand enough to be able to consent to the treatment, then their consent is not valid. And the treatment therefore shouldn't go ahead without that valid consent. So I think it would probably be about having a conversation with the patient, trying to sort of get to the bottom of why do they not want the information. Maybe they've had a difficult previous experience. Are they scared? Are they anxious? Are they afraid of things? You might have to explain that actually the treatment might not be able to go ahead if they don't understand some of the basic information. Maybe it's a communication issue. Maybe you need to go a little bit slower, speak a little bit slower, make yourself a bit clearer. Maybe it just needs a bit of time, to resolve it, and they need a bit of time to think about it. So, ultimately, you can't force a patient to have information. And if they insist that they don't want even the basic information, then it might be that you would have to record that and you wouldn't be able to proceed. But I'm sure that most of the time you're able to find a way forward by having those careful discussions with patients. So that's the scenario done on consent. Sorry, I'm just rattling through these. This is the last one now, I promise. Just to make sure we get done in the time. And it's just on complaints because complaints is a big area of issue. We deal with complaints on behalf of members every single day in high volumes. So we are quite well placed to see how they affect doctors and the sort of areas that these complaints arise from. And for anyone, if some of you are fresh-faced, you may not have actually received a complaint or been involved in a complaint yet. And as I said, unfortunately, it's almost inevitable that throughout your career, it might be that something hasn't gone to plan. A patient is dissatisfied despite your best efforts, and you are then faced with a complaint. And it's getting you to think about, well, how would that affect you, perhaps personally, and emotionally, because it can be very upsetting to receive a complaint. And I'm sure you can probably, if you haven't had a complaint, you can probably use your imagination and think that there would be quite a lot of negative emotions, negative connotations with this. It could cause a bit of anger, couldn't it? That you've done your absolute best for this patient, and for whatever reason that they're really unhappy. And that can be quite, anger-inducing. It can also cause a loss of confidence. Am I actually good at my job? Have I done the right thing? And it can be worrying about how it could progress as well, and it's going to be time-consuming. So there's a lot of negatives, and these are all completely justifiable emotions to feel. We have tried to counter that with some positive, and you probably think, positive, when it comes to complaints, what positive? But actually, I think always try to have a positive approach to complaints, in that they are a great opportunity for learning, for reflection, and hopefully for improving your skills and improving the service that you then provide to patients. Because it might be that the patient raises something that actually, yes, this is an issue that we need to sort out. So I think having that positive focus on complaints is the best way to go about it. And hopefully the culture in your practices that you go to work at will have that sort of culture. In terms of what patients want, I think most patients will want an explanation as to what's gone wrong when they complain. They want to feel that they're being listened to and taken seriously, an apology, an improvement to the service, and that sort of willingness to put things right. So in terms of then what they don't want and how they don't want to be treated, it's I suppose it's really the opposite of those things, isn't it? It's denial or trivialization. It's placing blame on other people or even on the patient themselves. It's making excuses for what's gone wrong, and it's putting barriers in the way of them being able to raise a concern or a complaint. So just have these things in your mind as well whenever you are sort of faced with a patient that you feel is unhappy and wants to raise that issue, whether that be verbally or whether it be in writing via email or letter or whatever form it comes in. I think as well, when members receive complaints, there is a tendency sometimes to panic and think, oh no, the world's going to end. And that panic and that emotional state, which people can then find themselves in, can then sometimes make them behave in an irrational way. And they can sometimes, forget key things such as confidentiality. So think about actually who is making the complaints. If it's someone other than the patient, do they actually have the authority to make that complaint on behalf of that patient? Do they have legal authority, something like a power of attorney, for instance, for someone that lacks capacity? So always remember your duties of confidentiality when you're discussing these sorts of issues. And then, of course, it would be unwise to panic and sort of go into the notes, into the records, and start altering entries, trying to make it look like you did something that you did until you didn't do something that you did. We have had members in the past, that have done that out of panic. And obviously that can then be misinterpreted as being dishonest. So we'd always advise that you don't, of course, do that, and don't disparage your colleagues. So get advice from your defence organisation and from your colleagues and people with experience, and they'll be able to sort of support you through this process. Just really quickly, going to have a quick look at how to deal with a complaint from an angry patient here. This is probably a pretty common example of a complaint that a lot of practices receive from time to time, with patients that have been kept waiting for, a few minutes for their appointments. So, sometimes it'd be quite tempting to have that emotive response to a complaint of this nature, wouldn't it? To sort of go, gosh, this is such a waste of my time. This patient had to wait a few minutes. Now I'm going to have to do this big response to this patient. I'm really angry. We didn't do anything wrong. And in the heat of the moment, that individual might send off a letter to the patient, which is, more confrontational than it should be, for instance. It might be there to prove that they're right and that the patient's wrong. And it's not going to be a conciliatory tone, which is what's required when you're trying to resolve complaints. So we always advise that complaints are reviewed by someone in the practice who is impartial to the issue, because they will take a more balanced view on it. And also, you can contact your defence organisation like us, and we can help you to actually draft the response that you're going to send out to the patient, so we can check it before you're going to send it as well. So, as I mentioned, you might get a little bit angry, like this angry patient, and fire off a response that you then regret. And so I'm going to show you this type of response. It's probably the more entertaining response that we'd all quite like to write now and again. So normally I get lots of nods of, oh yes, it'd be great to send that response out to the patient. However, do you think that's going to resolve that complaint? Is that patient going to read that and think, oh yes, I'm really satisfied with that response, I won't take it any further? Absolutely not. It's going to enrage the patient, and it's not going to go away. It's going to be another clutter of complaints. And what we sometimes see is patients then trying to escalate that complaint. So it starts as a local complaint to the practice, but then what they do is they then go to the ombudsman, or they might complain to the trust, or they might actually complain if it's about an individual GP, for instance, they might complain about them directly to the GMC. And that's all because the practice didn't handle it in an effective way initially. So when you get a local complaint, it's a great opportunity to diffuse it and to resolve it there and then, and stop it from escalating any further. So do get advice and support if you feel that you need it when you receive a complaint. So now I'm going to show you a good example of how to deal with this. So this is not as entertaining, unfortunately, as this response, but it is the right way to do things. And initially, I'm just going to show you a good example of an acknowledgement letter. So this is really just to say that you've received the complaint and that you're going to be looking into it. So I think this sets the tone really well. It also lets the patient know when they're likely to receive a response by. And when you're responding to complaints, you don't have to respond by a certain time or date. You don't have a set number of days. You set the time scale according to the complexity and the challenge it's going to be to actually investigate that complaint. But the idea is that once you set that date, and it should be a reasonable time scale, then you do try and stick to that. And if you're not going to, if there's an unavoidable delay, you should let the patient know and keep them informed. Okay, so that's the acknowledgements. So now we're going to look at the final response from the good practice that's doing everything properly to deal with this angry patient's complaint. So let's have a look at this in each section. So this is the sort of the opening, and you normally start with a summary of the patient's complaint, which they've done so here. And then this final paragraph here. Now we would we have quite a sort of catchy term for this, which is sad but glad. So I think always try and have that in your mind of this sort of sad but glad. That's the right approach and tone, which is I'm very sorry that you've had to complain and that you've not had a good experience, but I'm very pleased that you brought it to my attention so that we can do something about it and improve the service. So that's the sort of sad but glad approach that we would always try and take. The next bit of the response is what the practice and what the individual has done to investigate and look into the complaint. So great to be able to tell the patient that you've had a meeting about it as well, because that shows them that you're taking it really seriously and you're not trivializing it in any way. And then the next bit is the sort of, I suppose, giving the facts from the practice's point of view. So as is often the way, the patient got to their appointment 15 minutes early. So they were counting that 15 minutes within the time that they said they were being delayed. So I really like the way the practice has kind of put their view of events here to say, well, actually, you were only waiting for 32 minutes. It wasn't an hour. But the way they've done it is in a very factual and non-confrontational way. So they're not sort of saying, we're right and you're wrong. But it's putting those points across, but in a conciliatory tone, and also getting in another apology about the GP, forgetting to apologise for the delay, and a great little learning point there about the reception staff being reminded to inform patients if the doctor is running late. So normally you would then sort of sign off that complaint with, inviting them to come back if they've got any further questions or queries. And you might also leave the Ombudsman's contact details if they did want to take it any further. However, if that did go to, say, the Ombudsman, and the Ombudsman's, reviewed the complaint and looked at that response, there wouldn't be any case to answer. They would see that you've done a fantastic job of responding to that, and that actually there wouldn't really be anything else that you could have done. So I think, it takes a bit of time to prepare a complaint like this, a response like this, but it does the job of getting rid of it and resolving the situation. So I hope that's sort of helpful just to see a sort of, an effective response. But as I said, that's what you've got your sort of defence organisations there for, to really help you with these sort of day-to-day problems, because, you're not going to be experts in those areas. You're not going to want to have to think about these things all the time. So it's good to have that sort of support when you need it. So that's all of the scenarios that I've brought up. So just to sort of summarise, really, just always think about that sort of patient confidentiality, issues around consent and records, making sure you're keeping really good, comprehensive medical records. And if something does go wrong, always try and reflect on it, as has been discussed earlier, and consider how you might have done things differently, as that sort of continuous improvement, really. And of course, you can contact ourselves. I've just got a bit more information just in terms of medical indemnity, because I know that it can be a little bit of a minefield and a bit confusing for people. So essentially, back in 2019, NHS indemnity was extended for primary care for GPs, which means that you do have NHS indemnity in place for your NHS work. What does that mean? And does that mean that do you still need membership of an organisation like the MDU if you are an NHS employee, which most of you will be? So it's really important to know the limitations of the NHS indemnity, or what they call state indemnity, because the only thing that does actually accommodate is claims for clinical negligence. That arises out of your NHS work. That is what you would then put through the NHS indemnity, or what they call CNSGP, so Clinical Negligence Scheme for GPs. However, any other medico-legal issue that you have, the state indemnity scheme would not assist with any of those things. So the things that I've already talked about and are listed here. So if it's a complaint, you would go to your defence organisation for assistance with resolving that complaint. If it goes to the Ombudsman as well, if it's a disciplinary process, most importantly, the GMC, there's a fitness to practice investigation, the NHS wouldn't support you with that, your defence organisation would. So it's really important that you have that defence organisation membership in line with the NHS cover that you already have as well for the claims, and then it's sort of you're pretty watertight then. So that's just letting you know the differences there, which I hope is helpful, and I can obviously deal with any queries that you have at the end in relation to that. And then just a little bit about just because I know you're all ST1 trainees. So we have some educational resources which you might want to sort of tap into, which would hopefully help you throughout your 3 years of training and beyond. So you all currently will have a deanery arranged indemnity provider, but you can actually also join the MDU for free as a GP trainee. So it's completely free of charge, and it gives you access to lots of really essential and useful training tools and educational tools. So this is a QR code. You just need to scan that. My colleague Rebecca is going to just put a link in the chat or the Q&A. If you're having trouble to scan the QR code, so there's a URL there where you can go and pop your details in. Just to give you an idea, so we have a tie-in with a company called Red Whale, which are a well-respected training organisation, and there's over 900 written resources. So it's brilliant for consultation support, also to help you with your CPD, and also to help you with passing your exams whilst you're training. And there's a particularly important, I think it will probably be in year 2, but I think it's different in different areas, is doing the AKT. So there's an AKT topics digital handbook there for free as well. So by all means, do take advantage of that if you haven't already. It's really useful. And as I said, it's completely free whilst you're training for the whole 3 years. So you can sort of take advantage of that if you want to. So that's pretty much everything from me. There's just I just thought I'd get a bit of a plug in, if you don't mind, because we've got an IMG conference that's being hosted by the MDU on the 30th of April in central Manchester. And that's fantastic. You'd all be more than welcome to attend that conference. We've got some great speakers, all who are IMGs themselves and have made fantastic careers for themselves in the UK. And actually, by joining that free affiliate membership that I just mentioned, you can get a discounted ticket for that conference as well. If you wanted to come along, you'd be more than welcome. So Rebecca's put a link to the landing page on our website with all the details of the conference. If anyone is interested in coming along to that, it'd be good to see you all. So that again is the QR code there for the affiliate membership. So that's everything in terms of the presentation. I hope that was helpful. I'm going to stop sharing my screen now, and we can deal with any other questions that might have been added.
That's lovely. Thank you so much, Chris.
No problem.
Yeah, we're just checking on. Let's have a quick look. I think a couple of questions might just have come in. Okay, so let's tackle these live. I think Rebecca is going to sort out the link and the QR code. So the first question from Hamza says, oh, okay, if you can tell us the difference, Chris, you're the best person to answer this. If you can tell us the difference between the MDU and the MDDUS.
Oh
Go
gosh,
on.
yeah. Well, the MDDUS are a different organisation to us. They're based up in Scotland mainly, but we're both defence organisations. We're both member-based mutuals. For us, I suppose, just we're the longest established, and we've got the biggest number of GP members in the country. Also, by being mutual and Doctors for Doctors, our CEO is also a doctor, and we've got the largest sort of medico-legal advice team. So I'm sure MDDUS are also great and do a good job of supporting members. The main thing is, at least, as long as you do belong to one of the defence organisations, I think you're going to get access to support, and that's the most important thing. But obviously, it'd be better if you join the MDU, of course.
Of course, you say that, Chris. I know.
Yeah.
Yeah. Let me just tie that quickly in to the question from Anas that's just come through, and I'll go back to the rest. Is signing up for the MDU similar to MPS? As I received an email to sign up for that too. And can you sign up for both? I think it's really good that you clarified this for us, please.
Yeah.
Yeah, thank you.
Yeah, that's right. So a few years ago, the deaneries who you belong to, they started to provide the indemnity as a sort of a bulk purchase. And so they would go with one provider or another. So we've had some of the contracts in the past, but we might not have that contract in that area. So it might be MPS that are actually providing you with that indemnity. So that's why then you can actually join that affiliate free membership. That doesn't actually affect the deanery arranged indemnity with MPS, because our membership is purely an educational membership, so that you can get that access to the Red Whale educational resources. So yes, you can join both, and that's absolutely fine to do. And I would advise that you do that and get the most out of them.
Chris, I'm just, if you don't mind, just going to jump in on that question, because it answers another question that we've had in the chat. Someone's asked if the affiliate membership is only for trainees in England, and yes, it is, because in Wales and in Scotland, the defence organisation membership that Chris was just talking about isn't arranged by the deaneries. So it is your responsibility to join a defence organisation like us or MDDUS or the MPS. So because you can choose which defence organisation you join, you'd have to pay for membership with us or with someone else. So you're very welcome to do so, and then you'd still get access to Red Whale through us. But it isn't the free resource that is available just for people in England. So apologies for that.
Yeah, I think you can. Thank you, Becca, because I did forget to mention that. So apologies for anyone outside of England there in Scotland or Wales or Northern Ireland. But yes, you would source it yourself. Normally you can get that amount reimbursed anyway by the deanery. And then again, as Rebecca said, you can still access the free access to the Red Whale resources. So yeah, it's very similar.
Okay, thank you. And then Assad says, if we already have a membership with the MDU from a previous practice, do we need to alter our current membership to reflect that we're now in a training program?
Yeah, so what I would do is I would check with your deanery office and see what the deanery arranged indemnity provider is. If it isn't the MDU, then I would give the MDU membership team a quick call and just let them know that you've got a deanery arranged indemnity in place. And what they will do then is switch your membership onto the affiliate free membership. So then you're not having to sort of pay for it, and you're obviously getting the deanery arranged one, but you're still getting those GPST affiliate membership benefits.
Excellent, thank you. Okay, well, just to pick up on this, because I think there's a little bit of confusion. Someone says, but the Red Whale says discounted price for £88, and you just said it's free. Is there some error?
No. So the affiliate membership is totally free.
Free. Right. Yeah.
Yeah, absolutely. So I'm not sure where that £88 has come from. But it's Red Whale Knowledge. That's the package that you get. So I think that's normally about £120 a year to purchase. But you get that for free from us. I think if it was to do with a course or something like that, that would be something that you would need to pay for. I don't know if the courses are included. I don't think they are in the Red Whale Knowledge. But it's all the articles and publications and the AKT digital handbook that you get for free.
Okay.
Eman, you've got your hand up as well.
Yeah, I was just to add on to that point. So with Red Whale, it's its own sort of like resource, and with the membership, you can have access to their online resource, which is really, really helpful. So if you're ever in primary care, you can literally have it open in the background, do your consultation with your patient, and then have that open alongside, which can be really helpful. But Red Whale does sometimes do like 1-day courses, half-day courses, etc. And I think that's where the £88 comes from, because in certain training schemes and training programs, it might be that it's part of your full day. You do like a full day teaching with Red Whale, which you have to apply for study leave and expense leave forms and reclaim that expense. That is something that you need to just check with your own deanery to see if it's provided for you or not. So don't assume that you are going to get that claim back. It needs to just be checked, is the only thing I would mention.
Right. Thank you for that.
Thank you. Right. So somebody says, Nana says, could you please put up the QR code one more time? Would you please share the screen again?
Yeah,
please?
of course I can. Yeah, no problem at all.
While you're doing that, so that's done. While you're doing that, Hamza says, if there is clarification, because, he's looking for clarification, sorry, because the MDDU is the one that sent me the email to register with them, but I'm based in Cornwall. Should I register with the MDU since I'm based in Cornwall?
So again, if you're based in Cornwall and it's MDDUS that are sending the messages, then that means that it'll be the deanery approved membership is with them. But again, that means that you can still join the MDU for the free membership. So you can absolutely do both. So that's no problem at all.
Okay, so just looking at the
sorry,
time,
I'm just sharing this again.
No,
sorry,
yes,
I'm just
go
trying
on,
to.
Yeah.
Can you just let me know if you can see that? Okay.
Yes, I can see that.
That's the QR code again, just
yes.
if anyone needs it. But
Yeah.
I think Rebecca's put the URL link in the
it goes
again
to
as
the
well.
same place.
Thank you.
Perfect.
So we've got 2 minutes before we have to round, or before we need to end up. Anupam says, how much does it cost for GP registrars? Is it the Red Whale? I'm not sure which Anupam is referring to get MDU membership, or the next one says to get MDU membership.
So if you're it will be free if you're in England. If not, just give us a call and you can get a quote for year one. I think it's certainly under £100 for year one.
£48, I believe.
£48. Thank
Yep.
you, Becca. You're being very useful today for me. Thank you. Yeah, £48 for year one, and as I said, you should probably be able to get that reimbursed by the deanery as well, and then that gives you access. But if you're in England, it would be completely free.
And then there's a question from Azza Dawa, who says, when should registration be taken?
When should registration be taken? As in the I'm not sure.
I'm not very clear.
Yeah, I suppose just in terms of the setting up the membership, just do it as soon as you can, really, because the sooner you register with us, the sooner you'll get the access code to the Red Whale resources, which will help you obviously with that. So I think that's perhaps what it means.
Yeah.
But
so
yes,
they can start now before they start.
Yeah, absolutely. They can start now. They can just put their start dates on the form, and then we can get that all set up for them. Yeah, absolutely.
Lovely.
Yeah.
Okay. There's just one lingering here that says, attending the conference, we need to be GMC registered first. The conference you mentioned earlier.
Oh, okay.
Yep. So.
Yeah.
So that's fine. So we are just on 2:59, and I think it's just left for me to say thank you so much, Chris and Rebecca, for always very insightful and reassuring, because a lot of these things bring out so much anxiety. But thank you so much for clearing up the questions, giving us insight into complaints, negligence, and claims and how they work. Really appreciate your time today. And yes, see you again soon. Thank you.
It was a pleasure. Thank you. Nice to see you all, and have a good rest of your day. Thank you.
Thank you. Bye-bye.
Thank you.
As I hand over to you. Thank you.
Thank you, Sylvia. Thank you, Chris Hall, for such an informative session. We are honoured and privileged to have our Chair of Council of the College, Professor Victoria Tzortziou Brown. I'm going to introduce you, Professor Brown, first. So she trained as a GP in London and has spent over 2 decades working on the front line in East London, caring for patients in one of the UK's most diverse and deprived communities. She becomes the first international medical graduate to be elected chair of the RCGP. A long-standing faculty and national college leader, she has previously served as RCGP Joint Honorary Secretary with Dr. Jonathan Leach and London Faculty's Chair. She is the former college Vice Chair for External Affairs. She was awarded an OBE for services to general practice in the 2020 New Year Honours. Alongside her clinical work, she brings a breadth of experience in research, education, commissioning, and health policy. She is a research and innovation lead for North East London Integrated Care Board and a professor in primary healthcare and health policy at Queen Mary University of London Wolfson Institute of Population Health, where she also supervises GP academic clinical fellows and various other roles. I've just looked into your LinkedIn last night. Bless you. I need another 2 minutes. So very welcome to you, Victoria, and thank you for joining us this afternoon, and evening for some of the other trainee who still are back home. Over to you.
Thank you so much. Wow, it's such an honor to be with you. So as we draw to a close of this amazing day that I hope you have had, I would like to take a moment to reflect on what this day represents and what it means to welcome you into general practice and also into your professional home. So today is not just about induction. It is about arrival. You are here because you have earned your place in a competitive specialty in the UK. And that achievement really matters. It reflects your ability, your determination, and your resilience, often demonstrated across different healthcare systems, cultures, and challenges. And I want to say this really clearly and early. You are not here by chance. General practice needs you. There is pride in this moment, and rightly so. And there may also be relief. And for many of you, there may be a quiet sense of uncertainty that sits alongside this pride. For many international medical graduates, reaching this point is both a milestone and also a moment of reflection. Questions about visas, about long-term security, about whether you will be fully recognized and supported as you build your future. And I understand that, I get it, because I am an IMG too. Those questions are real, but they do not define your value, your capability, or your place in this profession. You are not temporary, you are not peripheral. You are colleagues, your future leaders, and an essential part of general practice in the UK. Now, it would be unrealistic not to acknowledge the wider context you're entering. You will hear a great deal about the pressures facing healthcare, about workforce challenges, about policy change, prioritization, And some of those conversations are necessary, and some can feel unsettling, but it is important to keep sight of what truly defines general practice. Because at its heart, general practice has always been about people, about relationships, about continuity, trusted clinical judgment in the context of real lives. And that has not changed. General practice remains the coordinated core of our health system, of our NHS. And it is where care is joined up, where complexity is held, and where patients are known over time. And that role, I think, matters now more than ever before. So through the work of the college, there is a clear focus on articulating that role with confidence, not just to policymakers, but to ourselves as a profession. General practice is not simply the front door to the NHS. It is where physical health, mental health, and social context come together. And it is where multidisciplinary teams work best when there is strong GP leadership. And it is where care is experienced as something coherent, continuous, and human. So as registrars, you will work across boundaries with community services, with secondary care, with social care. And in doing so, you will develop skills not only in clinical care, but also in coordination, in advocacy, in leadership. And those skills, in my mind, are not optional. They are central to who we are as GPs. At the same time, we know that for general practice to thrive, it must be a career that is sustainable, doable, and fulfilling. So let me say something about your future in this profession. General practice is no longer defined by a single pathway. It offers breadth, it offers flexibility, and the opportunity to shape a career over time. It could be portfolio working. It could be extended and specialist roles. It could be opportunities to develop education, research, leadership, population health, and digital innovation skills. And these are not signs of a profession losing its identity. They are signs of a profession growing in confidence. A sustainable career is one that recognizes these different stages of life, that supports return to practice, values well-being, and actively encourages leadership and development. And this matters, I think, particularly to international medical graduates who may be navigating additional pressures alongside training. So well-being is not a secondary concern. It is fundamental to delivering good care. You are also entering general practice at a moment of significant technological change and significant opportunity. Data, digital tools, AI are increasingly part of everyday practice. And I think used well, they can reduce administrative burden and they can support clinical decision-making and improve safety. But what they must never do is erode that relational core of general practice. The way I see it is that technology should serve care, not shape it. And it should give us back time. And this time is to listen, to think, and to care. So as a new generation of registrars, you have an important role in shaping how digital tools and AI are used, guided by evidence, guided by ethics, and also professional judgment. And I think you bring particular strengths here: adaptability, systems thinking, a perspective shaped by working across different healthcare systems. And those perspectives are invaluable as general practice continues to innovate responsibly. At the heart of our profession and of the priorities we are consulting on at the moment is a long-standing commitment to reducing inequity and supporting sustainable care. Health inequalities and sustainability are closely linked. Both are about value about using our time and our skills and our resources in ways that genuinely improve health and reduce harm. In our clinical work, in our clinics every day, we see the impact of inequality in patterns of illness, in access to care, in preventable suffering. So if we are not careful, care risks becoming fragmented, transactional, and low value. And inequalities, of course, will widen further. General practice has always pushed back against this, and we need to continue doing this by prioritizing continuity, by avoiding unnecessary over-medicalization, by supporting prevention and self-care where evidence is strong, by advocating for equitable policy, funding decisions, and inclusive professional environments. Many of you understand inequality, not just in theory, but through lived experience. And I think that insight strengthens the profession and will help us shape fairer healthcare, both in the UK and also internationally. So the priorities being consulted on are not an end point, they are a starting point, and they are being shaped through the ideas and challenges and insight of our members. And this includes you. You are not just registrars passing through, you are future partners, you are future educators, you are future leaders, innovators, and advocates for patients and communities. So the future of general practice will be shaped in consulting rooms and in teaching sessions and teams across this country and by voices like yours. I will be honest, general practice is not an easy career. We don't want it to be easy. It is a deeply human one. And it is stronger, wiser, and more compassionate because you are choosing it. So let me end where I began. Welcome, not just to training, but to a profession that needs your skill, your perspective, and your leadership. So welcome to general practice and welcome to your professional home. Thank you.
Thank you so much, Victoria, for such an insightful, with such a compassion as well speech. We're really grateful. You can see lots of sort of all the blouses and the hearts for you. Are we allowed some questions?
Yes,
Victoria,
of course.
is that okay? Yeah. So I've got one for you, and please put your Q&A, your questions in the Q&A box, colleagues. So last night I was looking into, because with the current employment crisis, I was looking at the website, our website, looking at the GP jobs. And I was really pleased that I can see that there are a section or option for on the advert for newly qualified and for the Tier 2 visa. So that gives a bit of reassurance for the GP, especially along the training, to see, yes, we will be able to work in the UK following a completion of training. But my worry is, I only found about a handful of posts. Is that because, is it free of charge, the advertisements to the practices? And I wondered if the practices, is it mandatory for them to mention that they are a sponsored practice or not? Do you have any idea, Victoria? Thank you.
Well, first of all, thank you, Azza, for highlighting the fact that there are bottlenecks out there that we really need to address. So we want more jobs for GPs and also more job opportunities for all GPs, including those that require visas. And this is a particular problem for general practice because in other specialities, of course, people train for longer. So by the time they qualify, it's easier for them to stay. So the visa issue is something very much on our mind, and we will continue fighting for it. But the practical issue of job adverts and whether practices are clear or not in terms of declaring whether they offer sponsor opportunities for visa is a good one, and I will take this forward. I think at the moment, I suspect in these adverts, people do not have to state whether they are sponsoring practices or not. And I think as a college, it would be good if we require them to declare that, because it will also make them sit back and think probably, and create a little bit of good competition between practices, and then act as an incentive to actually become sponsoring practices for visas going forward. So I will take this back. And also the issue of free adverts, that would be amazing if we can put it into place. I think as a college, we will consider it certainly, because that will probably include the increase the number of practices that advertise through our job adverts. So both issues, I will take them back. Thank you.
Thank you, Victoria. We've got a question from Olivia with regards to the job crisis. Will we ever see a UK graduate prioritisation for post-CCT jobs? A bit like the medical training bill prioritising UK graduates for training.
So how these detailed prioritization will happen, I'm not quite sure. What we want is, of course, by the time people qualify, there are enough jobs for all of them. And really, if you look at the evidence and the actual number of GPs that we have for our population, we don't have enough GPs, we know, compared to other countries. So we need to make a really strong case to ensure that the jobs are available for everyone who qualifies as a GP in the UK. And it is quite timely, this question, because we will be bringing a paper to our council in March. So those of you that have access to our members area, you will be able to see that paper. And we are going to be starting some work on calculating, modeling the number of GPs that we will need going forward in order to be able to deliver good care for patients. So I hope, to answer your question, that prioritization will not even have to come into account going forward, because there will be enough jobs for everybody. But yeah, we will be making the case.
Thank you so much. Thank you for clarifying, and clarifying regarding the council paper that will come very soon in 2 months' time. We've got other questions as well. So I'm conscious that we are run out of, we are over time, but they are quite hot topic. And I'm not sure, do you have the time?
Yes.
Okay, thank you. So as an IMG, how can we improve our chances getting trained? And the next question as well, I'm just going to say it together. So how soon should we expect the bill for CCT GPs being given ILR following completion be passed into law?
Well, with
Should we
regards to
start with the first question first?
So in terms of training generally as IMG, I guess this is beyond your standard training. If you want to look for other opportunities, is about networking, and that's what helped me to consider what other opportunities there are out there, especially if you would like to combine other things like training and research and leadership and all that. So definitely being part of networks, and the college is a brilliant network to be part of, and we have also special interest groups and lots of other faculties. Just get involved, and that will give you lots of ideas about what else you can do, and by talking to other people, you will also decide what would suit you at the career stage that you are and at the stage of life that you are. With regards to the second question, I cannot answer that because I don't know. As a college, we have a lobbying role on that, so we will do our best to make a strong case. But then what politicians decide to do is beyond our control. So yeah, we hope that we will be effective. And for the things that we can control, so for example, encouraging practices to become sponsored practices and all that, we will do as much as we can.
Thank you so much for all your insightful replies and being transparent with us as well, because that's what actually they like to to be with our trainee or registrars. I think I'll hand over now. Thank you so much, Sylvia, for your closing remarks. I'll hand over now to Sylvia for the closing of the event.
Thank you so much, Azza, and I would add my thanks to Victoria for being a star. I think you've been busy all day, and thank you so much for joining us in the very last minute and really being very inspiring and encouraging. So with that said, everybody, we've come to the end of this induction program. I'm confident you've picked up at least, I don't know, a lot of useful information as you start training. Can I ask you to please complete the feedback form, which is being shared in the chat by my colleagues? And we've also shared useful links for many aspects of the discussion today. Remember that your college is rooting for your success. We are solidly behind you. We believe in you. We are happy to have you here. We're here to support you every single step of the way. Join your local faculty as soon as you can. We've shared the faculty links, the college website. And that way, just as Victoria was just saying, you will learn about events, you learn about networking opportunities, courses, programs you can attend, clinical, social opportunities, and so on. On the college website, you'll find the area for the faculties. We shared that earlier. And if you click on the relevant one, you'll get the email address to the faculty administrator who will point you in the right direction if you're not sure. Also get to know your GP registrars, registrar representatives, the chairs, the co-chairs, the people that are your local faculty GP registrar representatives. Also across the college, there are several IMG representatives. They are there to provide support as well. I mentioned that I chair the special interest group for international medical graduates. So everything we are doing is to support you, help you celebrate, help to point you in the right direction. Many of your leads will be holding welcome events to meet you in your local areas. I hope that you'll be able to connect with those. It's been a privilege for myself and Azza to meet up with you, to talk to you, share information with you, and share this session. And I'll leave you with congratulations, very warm wishes, encourage you to believe in yourself, ask questions if you're not sure. Remember that you're a great doctor. You've worked hard to get where you are, and we know that you can and will succeed in your training, and we shall be there to celebrate when the time comes after you've completed. So have a very good evening, a very good night, and a safe trip to those who will be soon arriving to the United Kingdom. Thank you so much. I think the feedback form link should be going round, so let's leave this a little bit, to be shared.
And a huge thank you to Sylvia and Azza, who have been working tirelessly behind the scenes on the Q&As as well, and putting all this together.
Well, huge thank you to our GP registrars, the co-chairs, that they are working tirelessly with us with any of those nitty-gritty questions that very detailed, that needing a registrar to answer. So we're really grateful for all your support for the full day today. And Amina as well is here, and we're really grateful for Professor Victoria Torshu-Brown for being accepting our invitation and joining us today.